त्याला जास्त हात नका लावू, फक्त असं ठेवा, मग ते बरोबर येतं.
Good morning all. Distinguished speaker, distinguished guests, respected faculty, colleagues, professional, and my dear students. It gives me immense pleasure to welcome you all to the opening of Plexus 1.0, a scientific program designed to weave together the many dimensions of oral pathology through pathological, diagnostic, and surgical perspective. The word Plexus itself evokes the image of network, a beautiful interwoven system of knowledge, discovery, and growth. Just a nerve or a vascular plexus in the human body. From vital link to keep us functioning and connected, our program today reflects our mission to connect knowledge, practice, innovation in the field of oral pathology, oral medicine and radiology, and oral surgery by interconnecting radiographic and surgical points. Much like Plexus that supports and sustains complex biological function, this platform aims to build an interconnected community of scholars, clinicians, and the learners committed to advancing the oral health and scientific excellence. As your host, I, Dr. Kamlesh Dekate.
I, Dr. Neelam Rajpal. We are honored to guide you through this exciting journey. One that promises thought-provoking discussions, inspiring presentations, and meaningful interpretations. We are delighted to host a diverse audience today, from enthusiastic students and emerging researchers to accomplished professionals. Your presence is a testament to the shared vision of exploring the evolving landscape of OOO, where early diagnosis, precision-based therapy, and interdisciplinary collaboration are transforming patient outcomes.
This year's edition of Plexus is specially curated to cover a critical aspects of history taking, investigations, diagnostic advancement in molecular technique, and surgical perspective to the head and neck diseases.
I would like to extend a warm welcome to our esteemed guest speakers and all our participants. Whether you are joining us in person or virtually, your presence here reflects your commitment to scientific excellence and to building a better, more informed world.
Let this program be more than just an academic gathering. Let it be a hub of connection, curiosity, and the clinical evidence. Thank you, and let's make this memorable and impactful event. दो लाइनें इसके लिए मैं अर्ज करता हूँ. जुबां की खामोशी में एक कहानी होती है, हर दर्द की तस्वीर कहीं निशानी होती है. हम हैं पैथोलॉजिस्ट जो पहचानते हैं हर राज को, क्योंकि मुंह में छिपी हर बात हमारी जिम्मेदारी होती है. ना सिर्फ नज़रों से हम गहराई से देखते हैं, बीमारी के कारणों को जड़ों तक खोजते हैं। इस कॉन्फ्रेंस का मकसद भी यही है, ज्ञान का दीप जलाना और नई सोच को आगे बढ़ाना। It gives me immense pleasure to begin today's program with the auspicious lamp lighting ceremony, a tradition that signifies a dispelling of the darkness and awakening the knowledge. So I request all dignitaries to come up on the dais for the lamp lighting ceremony.
गजेशानाय भालचन्द्राय श्रीगणेशाय धीमहि।
Thank you, ma'am. Thank you, sir. I request our Dean, ma'am, Dr. Shivali Natarajan, to say a kind words or few words of wisdom to our audience.
Very good morning to all the faculty, the students and delegates who are gathered here. So first of all, I would like to congratulate the Department of Oral Pathology for taking this effort to organize this Plexus one, for the simple reason, I think today most of the conferences in all specialities are focusing on the role of AI, ML, digitalization and all these fancy stuff, which may be okay, we are on the helm of a change, but I think they have very, very thoughtfully chosen a topic which is going down to the basics. Because of late, for students as well as delegates, I would say that we have to realize the fact that somewhere behind the basics, that is clinical examination, history taking, radiographic interpretation, this is slowly and steadily fading away. So if we are going to give in everything to AI and computers and gadgets, I think our profession will get swept away very fast and we will not have a role. So, but I think medicine and paramedical services will be the last kind of profession to lose its job, for the simple reason that you will be able to see something which the machine is not able to see. So you will be able to do something which the machine will never be able to do. And you will be able to add that tinge or that flavor simply because of your analytical skills and your interpretation and your hands-on feel that you get when you examine a patient. So I think we should not lose sight of this very, very important fact. Whatever you gain, whatever you read, I think clinical examination with your hands, asking the appropriate questions in the form of history from the patient is going to mean a lot in making an appropriate diagnosis. And then of course, when it comes to radiographs and histopathology, again, I think both of these fields are immensely vast because there can always be multitude of variations which are not listed in textbooks and journals. So this particular forum today is going to concentrate on how you have to look beyond what you see, think beyond what actually occurs to you to really come to the closest diagnosis. So I think make full use of this. I was just telling Dr. Jigna, probably this should be the starting point. And very rightly so, Plexus, it's just not oral pathology. I think it applies to every single field in medicine. So it is important for an oral surgeon, it's important for a radiologist, it's important for all specialties to have some basic skills to diagnose and interpret. So probably Plexus 1 means it's not that. So we want to build up on this foundation. So this is like a foundation, or rather I would say a pre-foundation, All this we need to build up, take it to more complex skills, purely to make a good diagnosis, because ultimately treatment philosophies which we are prescribing and talking about in every single scientific forum, in all specialty conferences or in all specialties here, it makes sense only if your diagnosis is right. Otherwise, the starting point itself is wrong, and however best you treat, whichever laser you use, whatever you use, it doesn't make sense if your diagnosis is wrong. So I think I would just like to emphasize and reinstate that point in the minds of students, that arriving at an appropriate diagnosis is a very, very vital starting point, and that's going to define the success of treatment. So please pay attention to each of these lectures. They've taken a lot of efforts, because our foundations are getting weaker and weaker by the day. Thanks to all the computers and chat GPT, I think we are building castles on a very weak foundation. I'm sure some old-time teachers here will always agree with that. So students, don't fall prey to that. If your foundation is strong, you can build a multi-storied skyscraper. But if your foundation is weak, whatever you use to beautify your architecture, that's not going to stand. It's only a question of time when it's going to collapse. So all the very best to the entire team. Be very interactive. Ask questions if you don't understand. And I think I can only assure you that it's going to be a great learning experience. Thank you.
Thank you, ma'am. Ma'am, please be on the stage. Thank you for your word of wisdom. May I call upon Dr. Shilpa, ma'am, to give a token of appreciation for our speakers. May I call Dr. Jina, ma'am? Dr. Rohit Gadda, sir. Dr. Niharika Swine. Dr. Suraj Ahuja. Dr. Rashmi Hosalkar. Dr. Shraddha Gahisa. Thank you, Shrivalini. Thank you, Shilpa ma'am. So, I declare that this session has begins of Plexus 1.0. So, to start with, it's both an honor and privilege to stand before you today as we gather to discuss one of the most foundational yet often underestimated aspect of healthcare, the clinical history. In the age of dominated by advanced diagnostic, cutting-edge imaging, and the molecular technology, we must remind ourselves that the first and the most powerful diagnostic tool remain the patient's story, their history. For students and the young professional in audience, mastering the art of history taking is the first step to becoming a compassionate, competent clinician. For seasoned practitioner, it is a reminder that even the most sophisticated diagnostic tools cannot replace the insight gained from a simple, attentive conversation. बीमारी की शुरुआत वहीं से पहचानी जाती है जहां मरीज की जुबानी से कहानी बताई जाती है। क्लिनिकल हिस्ट्री कोई साधारण बात नहीं, यहाँ हर जांच की पहली और सबसे अहम कड़ी होती है। हर शब्द, हर अनुभव एक सुराग बन जाता है। सही सवाल पूछो तो सच सामने आ जाता है। ओरल पैथोलॉजी में जो इतिहास को समझ पाया, वही सच्चा निदान करने की राह पर चल पाया। I take opportunity to welcome Dr. Rashmi Hosalkar, who will explore the importance of case history taking through her academic experience. She has done her graduation from KLE Institute of Dental Sciences, Belgaum, post-graduation from MGM Dental College, and joined as an alumni in MGM Dental College with 10 years of experience. In research, she has various publications in international and national journals, including 13-book chapter and a book. She is awarded as a Best Oral Pathologist in years 2016 by FemDent in Mumbai. She is also past convener of Institutional Innovation Council. With that, I warmly welcome Dr. Rashmi Hosalkar to contribute to what I am sure she will be a highly enlightening the topic. Please.
टाकून लावा एक बार मॅग्नेट आहे ड्रेस एक वरतून एक बार
Respected Dean Ma'am, Head of Departments, my dear colleagues and students, thank you for giving me this opportunity to speak on the clinical implications of taking a case history. To start with, let's see what are the learning objectives that we will be doing today. So one is to understand the significance of comprehensive history taking, to identify what demographic factors are important in case history, to learn about how you have to question a patient when asking about a history to remove the answers that are required to come to an accurate diagnosis, and also to discuss the implications of a case history. So what is a case history? It's basically a detailed account of a person or an event. So when I say an event, in terms of death also we require a case history. What is the cause of death? Why did the death happen? What was the age? Etc. It basically is a foundation of an accurate diagnosis. Obtaining a detailed case history is said to be art. It's not the science of medicine. The purpose for obtaining a case history is to obtain a subjective data from a patient or their care partners. Now when I say care partners, that includes your wife, the husband, or your guardian, or the parent, or relative, or any friends or family that are accompanying a patient when he is in an unconscious state. As an incomplete history leads to unnecessary testing, delay in the management, and also probably sometimes a misdiagnosis. So that's why Sir William Osler rightly said, listen to the patient, he's telling you his diagnosis. And Macbeth Pitkin added that she might just be telling you the best management too. So what does a comparative case history includes? It basically includes demographic and biologic data, reason for seeking healthcare, current and past medical and dental history, family history. The added points are functional health and activities of daily living, and review of all body systems. Usually, all this is taken when the patient is admitted to a healthcare agency or the hospital, or when during the initial visit when the patient is arriving in your dental clinic or a physician place. However, the information that you get on the first visit should be corrected or at the following visit. So every time when the patient visits to you in the clinic, you have to redo the case history again. So if there is an added information or there is a deleted information that needs to be there, it has to be updated within the case history. Demographic data. What's a name? Name is a very crucial part of identification. It helps in establishing rapport and ensures accurate documentation and treatment. It helps in avoiding medical errors, personalizing care, and building trust between the patient and the healthcare provider. Age. Patient's age helps healthcare professionals tailor their approach considering age-related psychological changes, disease prevalence, and communication preference. Now, when I say psychological changes, always remember that there are certain hormones that are always playing a role. So when a person comes from a younger age to an older age group, there will be hormonal changes that would be associated. So in such time, you have to take all those things into consideration. Also the disease prevalence. Why? Because certain diseases will be concentrated only in younger generation, certain disease will be in the older generation, and certain disease will be in the middle generation. That's why age also matters when it comes into disease prevalence. Communication preference. When it is a young age, possibly the patient will not be able to communicate his history. So at that moment of time, the parent or the accompanying guardian will be able to give you the exact history. And in older cases, sometimes they might have a loss of hearing or loss of vision. At that moment of time, you will have to speak a little loudly for them to know what exactly you are asking for. Or if they may not be able to understand, so you have to simplify the questions more further for a better history. Gender. Gender interacts with other factors also, like the age, socio-economic status, and ethnicity to shape the patient's health experience, particularly for sensitive examinations. Now, when it comes to genital examinations or breast examinations, it has been observed that most of the times the female prefers to have a female doctor because they are more comfortable with it. So in such cases, you have to sympathize with that and make the patient go for a female doctor. Gender roles and expectations can influence health behaviors, exposure risk, and access to health care. Now, being a patriarchal family, it is always male dominated. So sometimes the females may not have access to the required health systems or the health care, where they have to depend upon the male in their family to take them to the hospitals, etc. So in such cases, even if maybe they might be having certain problems, but they may not be able to communicate properly, or they may not be able to go to the hospitals. So in such cases, that bias is also there. Female doctors spend more times on psychosocial aspects and preventive care, while the male more goes towards the technical aspects of management. Clinical trials have also been, this is a research that have proved that clinical trials have often excluded women, leading to lack of data on how treatment affects them. Biological sex, determined by genetic hormones and anatomy, plays a role in disease susceptibility and progression. Also, we have to take, nowadays we have to take consideration also the gender, that what you are born with and what you live with is different. So that also needs to be taken into consideration when you are taking a history, because possibly you are born a boy but you have the gender thing of female. So that all parts also needs to be taken into consideration while you are taking a history. Occupations. Many workers, many people, they have different types of occupations that are there. So we have people who are working into chemical factories, we have people who are working into industrial setups, we have people who are working as CEOs, etc., etc. It is not that a person who is a CEO will have less amount of hazards, health hazards, and the worker who is working in a chemical industry will have more hazards. It's not like that. It depends upon what exactly you are doing, how is your nutrition, what is your socio-economic status, how you are able to manage your health. So it can happen to anyone. So a person who is a CEO may be having a nutritional diet, but his lack of sleep, the nutritional value or the nutrition that he might be taking would not be proper. So that could cause an amount of stress that he would be having being at that position may cause certain diseases pertaining to those etiological factors. So similarly, when a worker is working into a chemical factory, he will be exposed to more amount of chemicals and other ingredients that could cause different symptoms. So that's why occupation is also an important part of a case history. Location. Again, location depends on different factors. So you have socioeconomic status or lifestyle. If you are living in an urban setup, something like that, so you will have diabetes, heart diseases, lung diseases again. Then if you have environmental factors, that means if you are living at a higher altitude or if you are living in a humid climate. So humid climates are more prone to lung diseases, etc. And altitude sickness will be there if you are living at a higher altitude. So different, if you have a poor oral hygiene or the hygiene is not maintained at the house, there are a lot amount of insects, bed bugs, bites, etc. So different diseases can occur due to these kinds of presence. Also, location is very important because certain diseases, we have a number of endemic diseases that are there in around India. So each and every disease has a particular location. So if you see, we have Kala Hazar that is more prominent in Bihar, Chhattisgarh. Then you have sickle diseases also that is more prominent in Madhya Pradesh and Chhattisgarh. Then you have chikungunya. Though I would not say that it is not located in other diseases, the prominence or the predominance of patients having chikungunya would be more commonly seen in Karnataka. So that way, where you come from also determines your medical history also, that possibly they might be having an episode of a chikungunya. So then comes that where did you reside before? So that such questions needs to be asked. So these are the few videos that are there, that what can happen if you spell a name of तिकडे घ्यायचे त्याकडे ते का नाही नाही येत आहे
स्लाइड किती तुमचे
35 काय हँग झालं नाही येत आहे नेट लावून द्या मी ही व्हिडिओ तिकडे घालते
इंटरनेट चालूच आहे
हां मग ही कॉपी करा आणि तिकडे घाला ठीक आहे ना
दोन्ही आवाज एकत्र
मिनिमाइज करा मिनिमाइज करा
म्युझिक बंद कर
छोटासाच आहे एकच वेळेला
आवाज वाढत
थांब एक मिनटं खूप ओपन
सेम बापरे
मध्ये काहीच नव्हतं एकच मिनटं
बस
नंतर तुमची माहिती ते
So you can see how a name can cause so much of mishaps. I hope you have observed what her name spelled like and what was typed. So 1K and 1C makes a hell lot of difference, if you can observe right now in this video. So these are the few focused questions that are there when you're taking history. So in terms of name, if you can see, what is your full name? Sometimes some patients prefer to be called by the name that they call them at their home or sometimes, so that kind of rapport can be built with them. So if you have to build a rapport with your patient so that you get a very detailed and a correct history, so you may sometimes need to address them by the name that they prefer. So that's how the focused questions come into picture. So similarly, in terms of allergies, it's a very important history that you need to take about. Like, do you have any allergy? You have to ask. If the patient says, no, I do not have an allergy, or I don't know, I have never tested for anything, but whatever I have had, I still have not got any allergy as such with it. So there would be the following questions that come. So whenever, if by eating something, have you got any swelling or have you got any itchiness that is there present? Do you remember that? So focused questions are basically questions that give you an perfect answer or the answer that you are required. When it's an expanded question or an expanded history, that means you require everything or all details about it. So when you ask focused question, it gives you answer pertaining to the questions that are you are asking about them. So similarly, preferred language. Now it's one of the most important thing in history taking is, supposedly I am from Karnataka and I know Kannada. I speak in Kannada, but I am not well versed with Marathi. And I come here as a patient to you, and I am not able to understand what you are talking, what you are saying, anything, because I come from a village background from Karnataka. But however, if you are not able to know what I want or what I am affected by, you will be not able to help me, or you will not be able to come for an accurate diagnosis. So at that moment of time, you have to look in for a translator. Why translator is required is because a translator may be able to help you or may be able to tell you what exactly the patient wants or what exactly the patient's problem is. So that's why preferred language is also a very important component of a case history. When you speak into a patient's language, the patient will be able to communicate more freely to you about his problems, about his life, or what exactly is happening over there. Reasons for seeking of health care. The patient's reason for seeking care are referred to as the chief complaint, or it is now it is called also as the main health needs. So when Yadanpalli did research in Andhra Pradesh, in the Tenali region, he took around 1,500 patients from that district, 2 from urban, 1 from lower urban, 1 from town, and 4 from village. So total of 1,500 people he took for his research. Out of those 1,500 people, 900 people never ever visited the dentist, and approximately 450 or 500 visited the dentist. And out of those 400 and 550, most of the common reason for seeking care was decayed tooth with pain discomfort, followed by gingival problems. And if you can see, the mucosal problems were the least in numbers that the patient actually visited for. So again, the focused questions or the focus assessment questions changes according to the setups. So if you have a clinic visit, the questions will be different, the way that you have to answer. If you have a hospital setup, the questions changes again, and the answer that you get will be different, and what expected from the patient will be different. And if you have an inpatient follow-up patient, then the question setup will be different. So for example, if I am taking in a clinic visit, so the first question will be, hi, Naveen, how are you? What brought you today into my clinic? So the patient might answer, I have pain in the tooth that does not go away. So the next question would automatically do, how long it has been happening? So he will say, since yesterday morning maybe, or since 2 days. How is this affecting you? It has not been making me to sleep, or it has been just troubling me, I was awake the whole night. So different questions will give you a different set of answers. Now, the set of questions are dependent on two types of way. One is called as the Socrates way, that is commonly followed. The newer method is the PQRSTU. So that's P stands for provocative palliative, Q stands for quality and quantity, R stands for region and radiation, S stands for severity, T stands for timing and treatment, while U stands for understanding. Usually the PQRST assessment is used for pain assessment, but also it can be used for other symptoms also. So these are the few questions related to pain and few questions related to the other symptoms. So I can give you an example for the provocation and the palliation. Palliation is nothing but the palliative. Okay, so provoke is what is causing the pus, or what is making the pain worse. But if I am taking an example of leukoplakia patch, so what makes the white patch feel worse, whether it is spice or whether it is drinks or whether it is certain other activities that it is causing. Palliation is what makes the pain feel better. So whether it is removing of, if I do not drink hot or cold, the pain is not there, or if I do not chew from that side, the pain does not come. And in leukoplakia, if I'm asking, it would be what makes the patch feel better. Whether if I avoid spicy foods, I do not feel the burning sensation or the pain sensation that is there. So these way you should have focused questions per se to the PQRSTU. Current and past medical and dental history, another important topic that is there. Now, what do you see from this picture? So you can see that the father is sitting far behind and he is smoking cigarette. The kid at that moment of time would have been having a passive smoking. Possibly because of that continuous passive smoking, when he is growing into an older phase, he would be having certain respiratory disease. So that's what is present over there. Now when the child is coming into a clinic at an older age and he is giving an history of respiratory disease, it will not come to our mind to ask the parent whether he was coming in contact with certain pollutants that were in and around it. What we would generally say कि तुम कहाँ रहते हो, कौन से एरिया में रहते हो, उसको कैसे हो गया, hot है, humid है. But we will never question कि are you smoking in front of him. So in such cases, the history from the parent also matters. So that's why it is very important that you take a history. Now, you have to inquire about the medical condition and diagnose, or medical condition for which the patient takes any medication. So when you are asking patient, are you taking any medication? So the patient will say yes. So for what you are taking medication. Sometimes the patient may not know what the diagnosis is, but he will show you the prescription or he will show you the medications that he is taking. And from that you have to take out the diagnosis, or possibly that patient might be having this disease. Sometimes the patient says that I am not taking any medications. In the lower class strata, it is always seen that because of the socio-economic status, they will not take the medications for as long as it has been recommended. But they usually take it for 1 or 2 months and they just leave it. So at that moment of time, you have to ask them that were you taking any medications before? Was there any surgery performed before for which you were advised any medications? And through that, you have to take out any medical history that is available. Why it is important? Because understanding the patient's risk factors, identifying contraindicated medications or treatments, and determining appropriate imaging modalities depends on all your past and current medical and dental history. So these are the certain focused questions that are there pertaining to the medical history. So you can have categories like current health, you have medications, you have allergies, you have childhood illnesses if any, or you have any chronic illnesses that they have, acute illnesses, surgeries, accidents, injuries, and even reproductive health matters when it comes to older females. How to ask the question? Tell me about your mental health. Why it is important? In nowadays life, mental health has been given the predominance. So what questions you will ask? The questions broadly focus on the health and invites a dialogue. A dialogue is very necessary when it comes to mental health, because when you do not have a correct session with them or a dialogue with them, it will be impossible for you to judge what exactly the patient is going through. Family history. Many diseases have genetic components. It is important to understand the risk and likelihood of a patient developing illness based on their family health. Ask health status, age if applicable, cause of death of immediate blood relative, parents, grandparents and siblings if they have a family history. So how will you ask family history? Tell me about the health of your blood relatives. Does anyone in your family have diseases like cancer, heart diseases or any respiratory problem? Have you of any of your relatives died because of this in recent years? So that's how you will remove the family history from them. Now why it is important? Because understand the risk of the cardiovascular diseases, respiratory diseases, endocrine diseases including coronary artery disease, chronic obstructive pulmonary disease and diabetes too. Family clinicians inquire more specifically into the history of myocardial infarctions, cancers and psychiatric or neurological disease to assess the potential risk factors. Social history. Now social history depends on three things. One is substance and nutrition. Sometimes in certain ethnicities, red wine, cannabis and other, they form the part of their diets and their rituals and their treatments also. Even diet is very important. So some people are, normal common diet is vegetarian, eggetarian, non-vegetarian, vegan. But there are certain different diets that are specific related to health diseases. That is your DASH diet, which is related to hypertension, Mediterranean diet and diet for diabetes. So there are different diets also that are there. And diets also have an impact on the nutrition level of the person. Travel history. Why travel history is important is because where he has traveled and are the symptoms pertaining to where he has traveled in the recent past. That is how you come to know whether that disease is related to his travel history. Sexual history is also very important because sometimes the patient may have multiple partners and because of which he may have a sexually transmitted disease. So we have to take care about that also. Now in components to substance or nutrition, so if you can see all the insufficient of lipids, what it causes, the oral symptoms that are oral signs that can be seen. There is insufficiency of proteins, shortage of micronutrients and shortage of vitamins, insufficiency of carbohydrate. Now it has also been found that there is a gene called as MTHFR gene. So when it is mutated, it decreases the folate levels in the body that causes cleft lip and palate in the kid that needs to be born. So all these things are very important. There are certain, in travel history, if you can see as such, there are many viruses that are there. We have experienced one, COVID. So similarly, there are different viruses. You have SARS, you have H7N9, that is the avian influenza virus that also comes from China. Then you have normal influenza virus, then you have Streptococcus pneumoniae, Haemophilus influenza. So there are many different viruses that have come and traveled across from other countries to India. So that's why travel histories is very important. These are fungi and parasites that have come. Then added part of the case history is functional health and activities of daily living. Now why this is very important? Now functional health assessment is collection of data related to the patient's functioning capacity, their physical as well as the mental. Now this functional health assessment is divided into two. One is activities of daily living and instrumental activities of daily living. Now what we say activities of daily living, that means daily activities. Getting up, going for a bath, having, maintaining the oral hygiene, eating, walking, sleeping. That's the daily activity. Apart from this, when you're doing additional, like you're driving a car, making a tea, cooking something, cutting the vegetables, etc. They are instrumental activities. That means they are helping the brain to function more. So basically why these are important is because they help you to know what is the condition of the patient's mental status. So depending on that, you will be able to guide the patient to an accurate diagnosis. Now what are the points that affect the functional health assessment? So they are nutritional, metabolic, elimination, that is your excretion, whether the excretion is good or no, whether he's having any indigestion that is present over there. Activity, exercises, whether he is just lazing around or whether he is active, he is doing walking, he is exercising and just maintaining the health. Sleep, rest, even that is an important factor. Sometimes some people like Narendra Modi sleep for only 2 hours or 3 hours, but at end of the day, in old age, possibly they can cause some serious problems. Cognitive and perceptual, role and relationships, sexuality and reproductive, coping stress tolerance, value belief, self-perception and self-concept. So these are the few focused questions that are there, that when you are asking about nutrition, elimination, mobility, activity, exercises, how you can remove the information from them. So if I tell about coping stress, so what you can ask is, tell me about the stress in your life. Do you have any stress? Have you experienced a recent loss in your life that has impacted you? This question was more common when it came to the era of COVID. Because in COVID period, we have lost many lives. Many families have lost their father, mother, son, daughter, friend, etc., etc. So at that moment of time, the stress level was tremendous. Review of body systems. Whether you have a medical disease or you do not have a medical disease, in US and Canada, it is mandatory that the body systems needs to be reviewed. Because there are few conditions that do not show up till the end. So that's why these medical conditions can show the oral manifestations that are present within. So you can, with the oral manifestations, you can identify that the patient might be having this kind of medical disease that is there. So for example, Alzheimer's disease or progressive dementia. So the oral manifestations that can be seen or observed would be poor oral hygiene, periodontal disease, dry mouth, dental caries. If a patient is having bulimia nervosa, he will not tell you that I am actually puking, I am removing everything from my body. But when you see dental erosion place, dental caries present, dry mouth and parotid enlargement, then you have to see, come for a diagnosis that yes, there might be something that is affecting it. So you have to ask the patient the occupation, what she eats, how much she eats, what's the frequency of eating, does she have any vomiting sensation, etc. And that's how you come to the diagnosis. Problems in case history, bias in case history. So following principles originally derived from the approach to neurocritical patients are applicable to all history addressing the bias. So this anchoring. Anchoring is nothing but you're only focusing on one aspect of the history when the new information is available. So possibly the patient would be having cardiac disease. But you are not seeing that the patient is also having anemia. So on the next visit when he comes also, you are just focusing on cardiac disease but nothing else. If the patient is having leukoplakia and on the right side, but he is having certain problems in his throat and somewhere etc. He is telling that I am not able to eat or I am not able to swallow. But you are just concentrating on leukoplakia but not relieving the problem that he is facing in the throat. Possibly there might be a lesion that would have been developed over inside in the nasopharyngeal area. Availability, based on the available information, deeming a diagnosis more. So you do not, you have like a linear approach, but you do not just divide everything properly and take into aspect every detail that has come in the history. But you say that, okay, I have a white patch, it is a leukoplakia. But what could be there? Whether it is a verrucous leukoplakia, whether the patient is having an HIV, do I need to look in for an HIV or do I need to look in for other immunocompromised history? You do not look into that. premature closure. That means I have come to a diagnosis, now I will shut that out. I will not going to do anything about, and I will complete the workup based on that. Similarly, like if a patient is complaining of a pain in a tooth, so it's a grossly decayed tooth, the treatment is extraction. I will not go to the radio, get a radiograph, see whether it can be saved or not saved, but just tell the patient, no, the teeth needs to be extracted. Representative restraint, forcing all history into one pattern of clinical presentation. Unpacking principles, focusing on some aspects of workup and omitting the others. And context error, considering all medical histories are equally relevant. Health literacy, Google patients. We have all Google patients right now coming to our clinics. So that's why it's very important for us also to know what the symptoms mean, what the signs mean. And we have to also be able to answer the questions asked by the patients. Digital Information Security in Healthcare Act, DISHA. Sometimes the patients are very apprehensive because they feel that their data will be given away in Google, or you will be sharing the data with some other person whom you don't want to, or you will take a photo of their lesion and you will paste it on the Google or the Instagram, etc. So in such cases, the patient becomes very apprehensive and they do not give an exact data that what is required. So for that, the Government of India, the Ministry of Healthcare has come up with Digital Information Security in Healthcare Act, that is DISHA. It is equivalent to HIPAA that is there in the US. Use of mobile application and artificial intelligence, like you type coronary heart diseases in ChatGPT and you get all the signs and symptoms, and then you look in for those signs and symptoms only in the heart disease patient. But sometimes the patient might come with a different sign and symptom, so you will not be able to evaluate it. Implications in case history. Though ethical and research has not changed much, the ethical guidelines have not changed much, but the relationship between the patient a physician has changed drastically. Initially, the physician used to be the authoritative person. So if the doctor is telling you have to do this test, no, this is only the diagnosis, the patient used to be like, okay, whatever you say. But now it is not the case. Now there is like a little bit of more friendliness, more opening is there. So because of that nature, you can have an accurate and a correct clinical history. The patient might feel that he will be able to tell you the exact history or all of the history that is required, or all of the problems that he is facing in life. So that kind of chain has been seen nowadays between a patient and a doctor. Importance of history taking may seem to be reduced because of improved technical diagnostics and therapeutics. Yes, definitely, because you go for anemia and they will tell you 10 number of tests. But if you take a correct clinical history with having correct signs and symptoms, possibly you will reduce the number of diagnostic tests that the patient is going to perform. It is a valuable part of various research methods, epidemiological research, prevalence research, incidence research, especially since it complements other approaches also. But it also contributes in the area of medicine that is not specifically research related, that is your education tool. Students in their early preclinical state might profit from creative approaches like small group workshops, so you can have a role play or you can have a virtual patient approach where they help in focusing basically on history taking and not coming on the diagnosis. So they will exactly learn what they can achieve from an history. So that's more important. And I think this is the future in our dentistry. So that's why we need to look into it. That is a role play or a virtual patient approach for students to have a better insight. So that's it. With this, I would conclude my case history presentation. Thank you all.
Thank you, Rashid, for giving us more of regarding getting a case history. Any queries?
Ma'am.
There is no queries. So let's go further. It is a great purpose that I welcome you on today's session focus on cornerstone and diagnostic excellence. The clinical examination, particularly in the field of oral pathology. A meticulous oral examination is not just about observation, it is the clinical judgment, pattern recognition, and communication. The oral cavity, as we know, often reflects a systemic health. Many serious conditions present with initial oral signs, from autoimmune disease and hematological disorder to early malignancies. In an era of increasing reliance on technology, we must remind ourselves that no scan or a report can replace a skilled eye and a thoughtful hand. A well-performed clinical examination is not only a diagnostic, it is therapeutic for it, reflects an effectiveness, expertise, and care. So today's session is a celebration of that clinical skills, of our ability to examine, analyze, and interpret what the mouth reveals. Whether you are a student refining your approach or a practitioner sharing your experience, this gathering is a reminder that our clinical acumen is a bridge between science and healing. हर लक्षण हर संकेत कुछ कहता है, अगर ध्यान से देखो तो मरीज खुद सब कहता है. क्लिनिकल एग्जामिनेशन कोई रूटीन नहीं, यह हर निदान की पहली सीढ़ी है. नजरें हो तेज, मन में हो संवेदना, तभी समझ पाओगे बीमारी की गहराई और वेदना. ओरल पैथोलॉजी में यही है असली कमाल, जब बिना कहे जान लेते हैं मरीज का हाल. Dr. Jigna Pathak is a currently professor in MGM Dental College and Hospital, Navi, Mumbai, in the subject of oral pathology and microbiology. She is dedicated and sincere teacher over 20 years of teaching experience. She has completed her undergraduation from Padma Shri D.Y. Patil School of Dentistry, Navi, Mumbai, and post-graduation from Nair Hospital and Dental College, Mumbai. She had done her PG certificate course in forensic odontology from IFS Pune. She has completed her fellowship in dental education from People's University, Bhopal. She has published several scientific papers in the national and international journals of repute. She is also a recipient of the Best Paper Award in 2019 at the IOMP National Conference, Trivandrum. I take this opportunity to welcome Dr. Jigna Pathak to enlighten her with your immense knowledge. Thank you.
A very good morning to one and all present here today. All the faculty, our ex-students, the alumni who's graced the occasion, we're very happy to see them. The postgraduate and undergraduate students. Now today's topic, this is the first time actually I've ever taken something on such a basic thing which can be generally used by not only oral pathologists but also by oral medicine and oral surgeons as well. And so today's topic is clinical examination. For clinical examination, to describe a lesion in a very systematic way and a systematic approach to describing a lesion is extremely important so that you can have a clinical bang-on or bullseye diagnosis. Okay? Of course, we sometimes have to have differential diagnosis as well, but if you have a systematic approach of describing certain pathologies or certain lesions, then coming to a diagnosis clinically is very easy to have. And we as pathologists face this very big problem because we never see patients, correct? All we get is the history and like magicians, we have to see the slide and just interpret what the diagnosis is. It becomes very, very difficult. That's one of the biggest difficulties that we have. And therefore, I chose this topic that when you systematically describe a patient clinically, it should be such that I sitting under the microscope should also be able to visualize what you are trying to say about the patient. The entire picture clinically should be in front of my eyes. That's how a clinical diagnosis should be. Because if we don't do that, then what happens is what is seen is deciphered and interpreted in a very different way by the terminologies and things that we use. That's why using correct way of diagnosing, correct terminologies and the description is extremely important. So by the end of today's session, you will be able to understand all the parameters which are required for intraoral examination. External examination will be taken by my colleague, Dr. Suraj, in the subsequent lecture. I will talk only about intraoral examination. You will be able to effectively describe the intraoral presentations of different types of oral lesions and in the end construe a checklist while describing the intraoral pathologies. So essentially, intraoral examination, we have soft tissue and hard tissue examination, but considering the time today, I will be focusing only on soft tissue examination of lesions. So any lesion in the oral cavity can present either as a swelling or a growth. Now many times we use these terms interchangeably, right? Swelling and growth. So swelling is just something that tells you there is an increase in the tissue volume, and it does not necessarily, and growth means increase in the number of cells in the tissue. So all growths are definitely swellings, but all swellings are not necessarily growths, okay? So we cannot ideally use this interchangeably, swelling and growth. Or the lesion may present as an ulcer, or it can present as a vesicle or a bulla. Now vesicle and bulla, ultimately when it ruptures, it will develop into an ulcer. So we will be talking only about few of these characteristics. Or the lesion in the oral cavity can present as a patch. That patch, finally when it heals, some of the patches form pigmentation, or it can be pigmentation de novo, either or. So primarily lesions need to be inspected. We all know that in our exams we have to write in our clinical history and in our clinical examination, we write on inspection and on palpation. So essentially each of these things I will be talking upon on inspection as well as on palpation. So when you talk about inspection of a swelling or a growth, either or, these are the different parameters. Now, I want you to listen to these. I have a lot of pictorial depiction and pictures and clinical pictures put up here. I want you to see this and remember these parameters, because in the end I'll be putting up some clinical photo and you'll have to write down, and maybe one of you can come and describe how do you describe that lesion, and let's see if you can incorporate all these parameters. All right. So coming to number, it can be either a single lesion or a solitary lesion, or it can be multiple lesions in the oral cavity. So we have to tell whether it's a solitary lesion or it's a multiple lesion in the oral cavity. Size, essentially, clinically, it is a two-dimensional number that we give for size, that is in vertical and in horizontal dimension. Only when the tissue is out can we have the three-dimensional effect of that. Shape, we describe the shape as either regular, that means if you can say that it is rhomboid in case of median rhomboid glossitis, or it's ovoid in case of certain swellings or certain ulcers. But if you cannot describe or give a specific shape to any particular lesion, then you say that it is irregular in shape. Like this one, this is irregular. The one before that you saw was ovoid and regular. Then site, it can either be a so besides telling whether it's in gingiva, buccal mucosa, palate, or wherever in the oral cavity, what is also important to be told is that whether it's a localized or a generalized lesion. So not only is this small globular swelling present in the labial mucosa, but it is a localized swelling, unlike this, which is a generalized swelling of the gingiva. So whether it is localized and generalized, that also needs to be, you need to be specific about that. Now, surface can either be smooth or it can be rough. When it is smooth, we all know what smooth surfaces are, but when it is rough, it can be different terms are used, like it could be nodular, or it can be papillary or cauliflower-like, right? So these are the different terms you use when it comes to the surface of a lesion. Color can be either normal color, same color as that of the oral mucosa, or it can be other than that. So other than that can be several. Most common are something called as red lesions, like a hemangioma, or a white lesion, which can be a verruciform xanthoma or a papilloma. Or it can be a blackish pigmented lesion like a melanoma. So the color also is of primary importance. Coming to the edge of the swelling or a growth, edge can either be well defined or diffuse, and the growth can either be sessile or it can be pedunculated. Here in this you can see it's a well defined lesion, whereas this is essentially a diffuse lesion in the right maxilla. This is a sessile growth, and this is a pedunculated growth. I'm very glad that in this 20 years since I've been in this institute, we've seen such lovely cases that all the pictures that you're seeing are cases witnessed in the department, and the photographs are of our own institute. So I thank the institute for giving me this opportunity to actually see almost every variety of lesion over here. So these are the different things that you see about or talk about a swelling on inspection. When it comes to palpation, obviously all the inspectory findings have to be confirmed on palpation, but besides that, you also have to see these particular parameters, that is tenderness, consistency, fluctuation, compressibility, pulsatility, and fixity. So obviously tenderness means you don't ask the patient whether do you feel pain. That's not tenderness. Tenderness means when you are pressing the swelling or the growth and the patient is experiencing pain, that's when you use the term that the swelling or growth is tender or is it non-tender. So inflammatory conditions are usually tender, for example an abscess, and non-tender lesions include, most of the neoplasms are non-tender unless secondarily infected, for example a fibroma or any other benign neoplasm. Coming to consistency, the consistency can be soft like in a lipoma, it can be cystic like in cysts, it can be firm, for example in fibroma, or it can be hard. Hard means it can be bony hard or it can be just hard. So that in any of these neoplasms, depending upon where it's originating from, the consistency can be defined accordingly. Coming to fluctuancy, now the swelling can either be fluctuant or non-fluctuant. Now what is important here in the first diagram that you see there, if it's a large swelling, you use 2 index fingers, put on either side of the swelling, try to press on one side and you'll feel the sensation on the other finger. So that is the test of fluctuancy. However, if the swelling is very small, like you can see in the second photograph, if the swelling is small and you just press it on one side, it can get displaced and give you a sense of false or pseudo fluctuancy. So to avoid that, what you have to do is you have to fix it with 2 fingers of the same hand and press it with the third finger or the other finger from the other hand, like you can see in these photographs, and that's when you can know it is a fluctuant or not, and that's what is called as Paget's test. So for small swellings, this is how you do fluctuancy, just not press it from one side because it can get displaced. Swelling can be compressible. We all know that compressible means it, so this is different from reducibility. When you say it is compressible, that means when you press it, after some time, it comes back. The shape is regained or taken back. Whereas when you say it is reducible or it's a reducible swelling, then it means that it disappears when you press the swelling. Okay, so many mucous, that's because the fluid gets displaced in the tissues. In the surrounding areas, that's why it gets reduced. So some swellings are reducible, whereas some swellings are compressible, and these cannot be used interchangeably. Next is pulsatility. Pulsatility, the swelling can be pulsatile if it arises from an artery or if it is close to an artery or it's a very vascular swelling. Okay, so what do you mean by pulsatility? That the swelling will rise with every throb of the artery. There are two types of pulsatilities, either expansile or transmitted. So when you put your finger on the swelling, if it raises and also separates, it is expansile, whereas if it is just getting raised, the finger, then you call that as a transmitted type of pulsatility. Fixity means it lacks mobility. That means when you hold it with two fingers, you are not able to move, then it is a fixed growth or a fixed swelling. This is very, very commonly seen in malignancies when they get fixed to the underlying muscles and bone. So quickly to recall, when you describe a swelling or a growth, you talk about number, whether it is single or multiple. You talk about size in 2 dimensions. You talk about the shape, whether it's regular or irregular. You talk about the site, besides being where in the oral cavity, whether it is localized or generalized. You talk about the surface, whether it is rough or smooth. You talk about the color, whether it is normal or other than normal, that is red, bluish, purple, black, whatever it may be, or brown, whatever, white, whatever it may be. And the edge, whether it is well defined or diffuse, or whether it is sessile or pedunculated. And on palpation, you talk about tenderness, consistency, whether it is soft, cystic, firm or hard, fluctuant or non-fluctuant, compressible or non-compressible, pulsatile or non-pulsatile, and mobile or fixed to the underlying tissues. Okay, so here's the picture, here's the swelling. As you can see, that's the mnemonic NSSSCE. You can form any mnemonic that you wish to remember these 7 things. And now you have to write down quickly in a minute, considering all this, how will you describe this swelling? Can you just note it and tell me how anybody can just note it and ensure that all these are incorporated in your description. Okay? For people who are listening online, can probably put it on the chat. N is for number, S is size, shape, surface, whether it's color, so these are all the short forms, yeah. Of the postgraduate students present here? Can anybody tell me? Anybody? It's okay if you are wrong. Any postgraduate students? I think oral surgery and oral pathology PGs are here, right? Come on, you have to just get up and read what you have described. And then we'll just see. Maybe you missed 1 or 2 things, or maybe it's just perfect. Doesn't matter. Anybody? Yeah? Can you describe? Okay.
Site can be localized swelling.
Okay.
Surface is smooth.
Okay.
Color is reddish. Erythematous swelling.
Or maybe just as that of the normal mucosa.
The color is of normal mucosa.
Okay.
And the edges are well defined.
Okay. So let's see whether did he see everything. So it's a solitary swelling. Instead of saying single swelling, I think when we are describing it as a whole, we can call it a solitary swelling. It is well defined, the edge, correct? It's well defined. He correctly said that. It's ovoid. It is present in the lower left mandibular region, extending from 3T to 3.5. Now, when he said and he described the swelling, if I had not seen the patient, I will wonder from where to where it is extending. So you have to describe it as a whole, so that even if I don't see the patient clinically, I should have the picture in front of my eyes. Okay, it should be that accurate. Measuring approximately, I said the dimensions have to be measured, approximately 3 by 2 centimeter in size, having a smooth surface, and the color of the overlying mucosa is same as that of the adjacent normal mucosa. Okay, so this is how you completely describe a swelling. All right. Okay, here's another one. Okay, fine. But before that, on palpation, now since we are just seeing the picture visually, we cannot really palpate, so I would write that all inspectory findings are confirmed on palpation. However, this swelling was firm to hard, which was non-tender, non-fluctuant, non-compressible, non-pulsatile, and fixed to the underlying bone. So this completes my complete clinical examination on inspection and palpation of one particular swelling. All right. Now there's another one here. Can somebody else try? Any other PGs? Any other department? Can you try and describe this? Come on, we are running short of time, so you need to get up and say quickly. Let's make it a little interactive. This is not so difficult. The acronyms are there on top. You just have to consider that and write down. Anybody? Any oral pathology PG? Yes. Okay, undergraduate student, thank you. Yes, tell me. You can try.
Ma'am, it's a solitary swelling in the mandibular right region. Ma'am, it's well defined. It's a single swelling, and ma'am, it's the shape is little bit of ovoid and little bit circular.
Okay. Okay, surface.
And the surface is not smooth, it's rough.
Rough, okay.
And little bit of yellowish to brownish patches, like dots are seen on the surface of the swelling.
Okay, very good. Thank you so much. So I would describe it like this. That's a solitary number, well circumscribed. So when you use these, when you are talking about growths, you can say well defined, well circumscribed, etc. Well circumscribed spherical swelling. Now I read somewhere that instead of saying round, it's always better to use the word spherical, because when you say round, you're talking about 3 dimension. When you're saying spherical, it can still be for 2-dimensional view. So that's why spherical is a better word. In the lower right lip, now this is not the mandible, it's a lip. I hope you can make out it's a lip. Okay, so it's in the lower right lip, extending onto the labial mucosa, opposite 4344 region, measuring approximately 5 centimeter in diameter, that's the size, having a rough, pebbly or papillary surface. So it is rough, yes, but if you can say it's papillary, pebbly, nodular, if you can make out, it's always better to write that or say that. And the color of the overlying mucosa is whitish with few regions showing yellowish black discoloration. So even when I read the whole thing, I should be able to visualize what this swelling would be looking like on the lower right lip. All right. Similarly, on palpation, all inspectory findings were confirmed, and it was firm to hard growth, which is non-tender, non-fluctuant, non-compressible, non-pulsatile, and fixed to the underlying muscle tissue. In the previous, it was fixed to the underlying bone. This is fixed to the underlying muscle tissue. So this completes your clinical examination as a whole. Coming to inspection of an ulcer. This was about swelling and growth. So these are the parameters that are important when it comes to inspecting an ulcer in the oral cavity. First is number, as usual, whether it's single or multiple ulcers. So you see single ulcers, you can see it in any kind of like a bullous lesion, vesicular bullous lesion. You sometimes see single lesions, or you can see multiple lesions. Like aphthous ulcers are multiple. In pemphigus shows multiple ulceration in various parts of the oral cavity. Size, again, you have to measure the size of the ulcer in 2 dimensions. Shape can be regular or it can be irregular. Okay, so normally malignant ulcers are irregular in shape, whereas, aphthous ulcers are usually regular in shape. Now coming to site. Site is, so this is a typical tuberculous ulcer which is ovoid in shape. So if you can make out what is the shape, you describe it. If you can't, then you say it's irregular in shape. Now site, as I said, besides it being where it is present, you can know whether it's present on the labile mucosa or whether it's present on the fixed mucosa. So there are certain ulcers which are present on labile mucosa, like your aphthous ulcers, your pemphigus and mucocutaneous diseases. They show ulcerations usually on labile mucosa, whereas fixed mucosa you see it in herpetiform lesions or in pemphigoid. Here you see ulcers which are present on fixed mucosa. Coming to margin, we call a margin of an ulcer is that which demarcates the ulcer from the intact normal mucosa. Okay, so there are different margins. It can be reddish, as you can see over here. When it is reddish at the periphery, that means that it is an inflammatory lesion or it's a spreading ulcer. So whenever the ulcer is spreading, it shows a reddish boundary, whereas if it shows a whitish boundary, okay, that I have not put the picture. If it shows a white boundary, that means it denotes fibrosis. So non-healing ulcers show a white boundary, whereas spreading or an inflammatory kind of an ulcer will show reddish boundary. All right. Now coming to the edge of the ulcer, edge is in 3 dimensions. There are different types of edges that we are aware of already, that it could be undermined, it could be punched out, it could be sloping, it could be everted, and it can be rolled out. Okay, so usually any of the ulcers, like a ulcer in mucormycosis or in tuberculous ulcer, you see what is called as an undermining ulcer. Can you see the edge over there? Now the edge, as you can see in the first schematic diagram, margin is where what separates the ulcer from the adjacent mucosa, whereas edge is the connection between the margin and the floor. All right, so that edge over here, you can see in the clinical photograph that it's undermining. Okay, it is undermining. So infectious ulcers like that of tuberculosis, etc., show this undermining kind of edge. Then carcinomas show everted margins. Okay, carcinomas show everted margins. So it's not only raised, but it's also everted. Whereas basal cell carcinoma, that was squamous cell carcinoma, whereas basal cell carcinoma usually shows what is called as a rolled margin. Can you see the last picture here? It is raised, but it is not everted. It is just rolled. So you can appreciate that in the photograph over here. You can appreciate the rolled edges. Okay, you can appreciate the rolled edges. Floor is the part where you see either the slough or bleeding area or granulation tissue, etc. So floor can have either of these things. If it's healing, it may have granulation tissue like you can see over here, whereas if it is not healing, it may have a slough which is present over there. You can see the yellowish, this thing over here, which is the slough. Sometimes it may also show some kind of discharge. And coming to the surrounding areas can be red if it's a spreading ulcer, and it can be hypopigmented if it's a non-healing ulcer. So can you see this area which is less pigmented or slightly whitish? So if it's a non-healing ulcer, it will show like this fibrosis, or the surrounding areas may be hypopigmented, whereas if it is spreading ulcer, then it can show a red surrounding area. All right, so this is how you inspect an ulcer as a whole. Coming to palpation, of course all inspectory findings have to be confirmed on palpation. Besides that, you have to see the surrounding area, the edge, floor, base, and the fixity. So surrounding area can be tender or non-tender. The edge can be soft if it's a healing ulcer. It can be firm if it's a non-healing ulcer, and it will be hard if it's a malignant ulcer. So you palpate the edge as well. Then floor may have slough like in any of the infectious ulcers, or it may have a bleeding area. So normally if it probes on bleeding, then if it bleeds profusely, then it's a malignant ulcer. So the floor of the malignant ulcer, when you palpate, it bleeds profusely. The base is that tissue on which the ulcer rests basically, okay. So if the base is firm, it may be due to fibrosis like in any chronic ulcer, but if it is hard or indurated, then you see that in malignant ulcer. So how do you palpate the base? It is through the floor, okay. You palpate the base through the floor and see whether it is hard or whether it is fibrosed, And fixity, again, you fix the ulcer with your 2 fingers and try to move it if it is fixed to the underlying tissues or not. So these are the parameters that you see of an ulcer on palpation. Alright, so quickly to revise, in an ulcer on inspection, you'll say whether it's single or multiple. You'll measure the size in 2 dimensions. You'll see whether the shape is regular or irregular. Besides where it is present, the exact location, you will also mention whether it's present or see whether it's present on labile or fixed mucosa, whether the margin is regular, irregular, inflamed or fibrosed, whether the edge is undermined or punched out, sloping, everted or rolled, whether the floor has slough or granulation tissue, and whether the surrounding area is red or hypopigmented. So these are the things that you see or inspect in an ulcer. Coming to palpation, you see whether the surrounding area is tender or non-tender, whether the edge is soft, firm or hard when you palpate, whether the floor has slough or whether it's bleeding when you're palpating, because malignant ulcers are known for that, whether the base is firm or indurated and hard, and whether it is a movable or a fixed ulcer. So these are the parameters that you feel when you feel an ulcer. Okay, so now here you have an ulcer. You have the acronyms there. Quickly write down, how will you describe this ulcer? We saw how you describe the swelling and growth, right? So somebody has to tell me, how will you describe this ulcer? Number, size, shape, site, margin, edge, floor and surrounding area. Okay? Anybody? Can anybody describe? Can you give it a try? Come on, somebody give a try. Yes. Yes, Suresh. We cannot hear, sorry. Can you give him the mic? Thank you.
It is single ulcer, size approximately 1 into 1 centimeter. Is located in the posterior to it, palatally. Shape is irregular shape. The margin is slightly elevated and undermined. Edge is undermined, and floor is slightly. Surface is irregular and surrounding area which is inflamed in nature.
Okay, thank you. So let's see. So always it's a good idea to write it down so that you don't miss out anything instead of just saying, because then you'll go haywire, all right? Okay, so it's a solitary, that is number, well defined, that's the surrounding the edge. It is a non-healing ulcer. Now this is very important to say, it's a non-healing ulcer. How do you make out it's non-healing? You can make out because of the edge, correct? Because of the shape, the edge, the floor, what it contains. So it's a non-healing ulcer in the left posterior palatal region, opposite to 2-7, involving the palatal mucosa and measuring approximately 3 by 2 centimeter in size. It has a red, inflamed, irregular margin with raised everted edges, and the floor comprises pinkish granulation tissue and a hypopigmented surrounding region. When you can see it's whitish, the surrounding area. Okay, so it's hypopigmented. That means it's a chronic ulcer. When the ulcer is chronic because of fibrosis around, it shows that whitish margin. All right. If it's a spreading ulcer, it will show red. If it's a long-standing chronic ulcer, it will show fibrosis. So on inspection, on palpation, all inspectory findings were confirmed. Besides that, the ulcer was tender, hard, and had an indurated base. Base is always only on palpation, okay? It is fixed to the underlying parietal mucosa and it bleeds profusely on probing. So all these have to be present when you are describing an ulcer on palpation. Next, it could be a patch, right? We did it, any lesion in the oral cavity can be a growth, a swelling, an ulcer, or it can be a patch. So these are the different parameters for patch, where it can be a focal or a multifocal lesion. Can you see? It's on the both sides of the parietal mucosa. It can be a focal or a multifocal lesion. Then you again measure the size in 2 dimensions. Site, very important where it is present. Now some are classically seen bilaterally like lichen planus. Okay, oral lichen planus is seen bilaterally. It's a bilaterally symmetrical lesion. So it's important to say whether it's a unilateral or a bilateral patch. Okay, then coming to color, it can be white, it can be red and white, it can be translucent or opaque. Okay, so these are the different presentations. It can be white, red and white, translucent and opaque. The borders can be distinct. Can you see in the gingiva the borders are distinct and well delineated. However, otherwise in the buccal mucosa and the labial mucosa it is a diffuse lesion. You don't know where it starts and where it ends. So the same patient, some areas are distinct and some are diffuse. And whether the surface, how is it? How is the surface of the patch? Is it smooth? Is it wrinkled? This is what you call as wrinkling or a cracked mud appearance. Is it nodular? Is it verrucous? Or is it papillary? Okay. On palpation, so on inspection, we recall quickly that it can be a focal or a multifocal lesion with a size in 2 dimensions. Shape is roughly, if you can tell what shape it is, fine. If not, then irregular. Site, whether it's unilateral, bilateral, and where exactly it is present. Color, whether it is white, red and white, or translucent to opaque. Borders, whether they are distinct, well delineated or diffuse. And surface, if it is smooth, wrinkled, nodular, verrucous, or papillary. So these are the components of describing a patch on inspection. On palpation, you just see the surrounding area. You see whether the texture, whether it is rough or smooth, and whether it is thickened. Now, here's a patch for you. Number, size, shape, site, color, border, and surrounding area. Quickly describe this patch. Anybody can try to describe this patch, okay? Number, size, shape, site, color, border, and your surrounding area. Can anybody describe this patch? Yes.
The lesion is focal. Focal. The size is approximately 10 centimeters. The shape is irregular. Site is dorsolateral border of the tongue. Then it has white reddish patches, and it is border is distinct. The surface is wrinkled.
2 arrows. One is wrinkled, the other one?
Other one is very
yeah, maybe papillary.
Papillary.
Yeah, or pebbled. Okay. And surrounding area?
Surrounding area is
normal. Okay. So we can describe this patch as a focal, that is a number, well demarcated, right? It's the border. I have drawn the border there. So it's a well demarcated lesion. Color is white, so it's a white patch. Roughly ovoid. Can you tell it's roughly ovoid? Okay, it's roughly ovoid. Measuring approximately whatever is the size in 2 dimensions, you have to write that. It is seen on the left half of the dorsum of the tongue. Can you see it's exactly, it is so huge that it's covering from the midline of the tongue to the almost the lateral border, and it has a wrinkle to a papillary surface. It has a wrinkle to a papillary surface. So this is a description on inspection. And on palpation, all inspectory findings are confirmed. Besides that, the lesion is rough, thickened, well demarcated from the adjacent normal tongue mucosa. It is a well demarcated lesion. Okay, coming to the last part, it can be a lesion can also be a vesicle or a bulla. Here also it's important to see whether it's single or multiple. Singular vesicles like this, initial cases of OSMF. This is a patient of oral submucous fibrosis where we have seen vesicles which are present on the soft palate, or it can have multiple vesicles or bullae which are present in a mucocutaneous disorders like pemphigus and pemphigoid. Besides that, the size, we all know vesicle is less than 5 millimeters. Some textbooks say less than 1 centimeter in size, whereas bulla is more than 5 millimeters or more than 1 centimeter in size. And site where exactly it is present, whether it is again focal or multifocal. So same principles apply even for a vesicle or a bulla, because ultimately it's going to rupture and form an ulcer. Okay, so then you have to give the description of ulcers. Pigmentation, again, whether it's a focal pigmentation like you can see over here, or whether it is diffuse like you can see in this other picture. Okay, it is diffuse. Color, it can be hypopigmented. Can you see the first case here? It is, this area is slightly hypopigmented, more whitish as compared to the adjacent mucosa. This entire area is hypopigmented, or it can be hyperpigmented. Everybody is aware about hyperpigmentation, right? You see blackish brown dots, physiological or pathological. Some lesions on healing heal with pigmentation like leukoplakia and lichen planus, because the melanocytes are stimulated and they produce excess of melanin, and that's why you see pigmentation when the lesions are healing. So first the patient's concern is that they have red and white lesion in the mouth. After some time when you treat that, the patient complains, and patient's grievance is, now my entire oral cavity is becoming blackish. That's a normal phenomena that we all must know. So I hope you enjoyed this lot of cases. Thank you very much.
Thank you very much, Jena. It was a wonderful lecture that I hope everyone has clear in depth how to take a case history, as well as how to do a clinical examination of a lesion. Any queries? Any questions?
Mike?
Any questions? Thank you.
Our next lecture will be on extraoral examination. So it is with a great pleasure that I welcome you all again. Today's clinical session on examination of the cervical lymph node and the temporomandibular joint. Two anatomical regions of a critical significance in oral pathology and clinical diagnosis. Both the cervical lymph node and the temporomandibular joint plays a vital role in the assessment of orofacial disease, ranging from infectious conditions and neoplastic process to systemic illness and functional disorder. So Dr. Suraj Ahuja, I welcome Dr. Suraj Ahuja for this lecture. He is a consultant and associate professor in the Department of Oral Maxillofacial Surgery, MGM Dental College and Hospital, Navi, Mumbai. He has done his diploma of a membership of Faculty of Dentistry from Royal College of Physicians and Surgeons of Glasgow, a fellowship of International Association of Oral and Maxillofacial Surgery, a fellow of Pierre Fauchard Academy, and board certified instructor of advanced trauma life support accredited by American College of Surgeons and the basic life support accredited by American Heart Academy. A clinical lead at Veda's lab, that is virtual engineer design assisted surgery, with a special interest in the virtual surgical planning and 3D printing in craniofacial reconstruction. So here I welcome Dr. Suraj Ahuja to share his surgical knowledge and skills to the enthusiastic crowds.
Hello. 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 Hello.
ये बन लाऊंगी Kumar. A very good morning, everyone. At the onset, I would like to thank the organizing committee to give me an opportunity to speak on these basic topics. So this particular lecture today, I have broken it into two parts. The first part would be assessment of cervical lymph nodes, and the second part would be assessment of the temporomandibular joint. I will be showing a presentation first for around 10-15 minutes to tell you what all we need to see when we are examining that particular system. And then one of our students, Shantanu, has volunteered. Thank you, Shantanu. On him, I will be demonstrating how do you go about clinically assessing that part. Okay? Let's keep this session a bit interactive, guys. So if you have any doubts, you can ask me at the end of that particular session or in between also. Okay? Don't be nervous. In fact, I should be nervous because I have to speak in front of teachers who have taught me. So all these are my teachers, and now I am to teach you the same thing. Unfreeze. Okay. ते रिवर्स करायला लागेल डिस्प्ले सेटिंग या डुप्लिकेट करूँगा स्क्रीन. Yeah, okay, good morning. So the first topic today will be clinical assessment of cervical lymph nodes. So by the end of the lecture today, we all will be able to understand what are the key landmarks to assess this lymphatic system, demonstrate the examination technique, and see what are the recommended basic investigations that we need to do. But before I begin, a very simple question. What do you understand by the lymphatic system? Anybody? What is a lymph node? What is the lymphatic system? Anybody? Because before we start going into the system, you should have a brief idea of why do we need to know this. Why you as a student or a dental practitioner need to know about assessment of cervical lymph nodes. Anyone? Come on, anyone? I will start picking students up. Come on, anyone? Nikhil? What is lymph? What is the lymphatic system? Anything, whatever you feel. Anyone?
It is a network of lymph nodes which are present inside the body.
Okay, good. Fine. Why is it important for us to know? So basically, the lymphatic system is a channel within the body which contains lymph. Lymph is nothing but a clear milky fluid which helps in regulating our immune system. Okay? So when we go about assessing this system, what does a lymph node tell us? Okay, you all would have heard the phrase, a smile speaks 1,000 words. So when you see a patient with an enlarged lymph node in the neck, what story does that tell? The first is the site. The lymph node in the neck may be enlarged primarily because of an infection, a tumor, an autoimmune condition somewhere else in the body, in the oral cavity. So it gives you an idea about where is the site of the primary infection, because generally the lymphatics from one subsite is drained in a particular level of the lymph node, which we will see. Second is the node type. When you palpate this node clinically, depending upon how it feels, it gives you a reflection of the underlying disease. Thirdly is the chronology. Okay? It's like a ladder. You have different levels of lymph node. So when the disease progresses, it starts involving the different groups of lymph nodes in a particular sequence. So if you can catch that, you can also assess the chronology of events that lead to the disease. And lastly, it acts as a systemic marker. A lot of autoimmune diseases and malignant conditions which are rampant in the body also manifest clinically as lymphadenopathy, or that is enlargement of the lymph nodes. Everyone clear? So now, as Jigna ma'am already told you, what are the key things that you have to do during any assessment? That is inspection and palpation. So when you inspect the cervical lymph nodes, you look for site depending upon which level the node is, the number. Then you check for symmetry. There may be an asymmetry because of a swelling somewhere in the neck. Thirdly, you check for any surface of the skin changes. In the lymph nodes in the neck, generally you may have scarring or you may have pus draining from particular lymph nodes if they are secondarily infected. And surface characteristics, whether it is smooth or nodular. We will speak about everything in detail. And then when you palpate, you basically what you do is you are confirming all your inspectory findings. You check for tenderness. You check for the consistency of a lymph node. Okay, they can be soft, they can be hard. They can be rubbery, they can be stony hard. They can be fixed, they can be matted. Lot of permutation combinations. We will speak about each one of them. And ultimately what you do is you take the patient as a comparator, and if he has some palpable lymph node on one side, you use the contralateral side as a comparison and you palpate both sides. So before we begin into the subsites, after listening to this much, how many of you feel generally during a clinical examinations in a normal individual, are the lymph nodes palpable? How many feel they are palpable? None. How many feel they are not palpable? Very good. Okay. So in a healthy individual, generally you do not see enlarged lymph nodes and they are in general not palpable. There are a few cases in where there can be an idiopathic cause for enlarged lymph node, but that has to be correlated clinically to rule out any underlying disease. So now coming on to the next part, that is classification of these lymph nodes in the cervical area. It is basically divided into 6 groups, is what you need to understand, depending upon the anatomic subunit where they are present. Okay? So the first one that we see is the submental or the submandibular group of lymph nodes. Okay? Because they are present just below the mandible. So the submental lymph nodes are bounded by the anterior belly of digastric muscle, which is here. So in between them you have one group. Okay? All other groups are bilaterally, but submental is present in the center, in the midline, near the submental triangle bounded by anterior belly of digastric. After that you have the submandibular group of lymph nodes, which are bounded by the anterior and the posterior belly of the digastric muscles. Okay? So this is level 1. Level 2 group, level 2, 3 and 4 are known as jugulo-digastric group of lymph nodes. Why? Because in the neck we all know there is a jugular vein. So it goes from here till here. So all the lymph nodes along the jugular vein are known as jugulo-digastric group of lymph nodes. Now these are divided into level 2, level 3 and level 4. Okay? Depending upon the distances between the anatomic subsets. So level 2 group of lymph nodes extend from the jugular fossa up till the hyoid bone. Okay? And they are known as upper jugular, means they form the part of the upper part of the jugular area. They are divided into 2A and 2B. Now this division is because of a nerve which passes through that is known as spinal accessory nerve. That classifications comes when we are doing a surgery known as neck dissection or for radiological investigations. Clinically, you will always say it is a level 2 lymph node. Okay? Coming next, you have the level 3. Level 3 is bounded superiorly by the hyoid bone and inferiorly by the cricoid cartilage. Okay? It's on the mid part of the jugular area, and the last part is the level 4 in the jugulo-digastric is level 4. Okay, it's the lower jugular group of lymph nodes, which is again divided in level 4A and 4B. So this comes in the anterior triangle of the neck. When you go to the posterior triangle of the neck, you have level 5 group of lymph nodes present there. Now this level 5 is also divided into 5A generally and 5B by this muscle known as omohyoid. Lastly, you have group 6. These are midline group of lymph nodes. Okay, they are basically present near the pretracheal and the prelaryngeal area here, right in the midline. Is everyone clear? So you have level 1, 2, 3, 4, 5 and 6 that you need to know. Apart from these cervical nodes, there are many more nodes which are present in the facial area, near the preauricular area, near the retroauricular area, near the occiput area. Okay, each specific for its type of clinical manifestation that it may present. Does anybody know how many lymph nodes are present in the head and neck area and how many lymph nodes are present in the body? Any guesses? Anyone? How many do you think? Guess? You take a guess. No. Okay, so generally in the body we have around 400 to 800 lymph nodes. Okay, 4 to 800 lymph nodes, out of which you have 300 to 400 lymph nodes in the head and neck. Okay, so 50% of the lymph nodes in the entire body are just present here. That's why it becomes very, very important for us to understand this system. Now going on to the next slide, this is basically the crux of the entire presentation. Clinically, how do you feel the lymph node and how does it manifest? I will show you the way to assess a patient, but what are the interpretations? So if a lymph node is soft in consistency, tender on palpation and mobile, it is generally because of a infection. Okay, it is generally because of an infection, maybe a tooth abscess or a space infection in the oral cavity. If the lymph node is hard, stony hard, fixed, non-tender, and since a long time, it is suggestive of a malignant lymph node. So hard, whenever a lymph node is hard, it is hazardous. You should understand, it should alarm you. Any lymph node that is hard is mostly characteristic of malignancy. After that, you have accumulation of a lot of smaller nodes together. So that takes place in TB. If it's rubbery, tender, may not be tender and movable at times, it is generally a systemic response when you have multiple lymph nodes in the neck. That can take place in lymphomas and HIV. Okay, multiple lymph nodes in the neck, they're rubbery in consistency, enlarged, may be movable, may not be movable, but unspecific. That is this. If the lymph node is fluctuant, warm, okay, it's fluctuant, tender, warm, erythematous, it's generally suggestive of an infection. Okay, in this you have to see whether it is acute or chronic depending upon the time frame since it's there. Clear? Any doubts in this? Now going on to the next part, what are the relevant investigations that you can do when you have a clinically palpable and a symptomatic lymph node? Now you have clinically palpated somebody, you feel there is an enlarged lymph node with these characteristics, but what do you do next? Call somebody, send the patient, okay? So these are a few tools that you can do. First one is fine needle aspiration or FNAC. The idea is for a very basic investigation. It basically tells you the differences between the cellular structure of whatever you get in the aspirate, whether it is a reactive, an infective or a malignant node. Now what is reactive? Reactive node is you may have one node here which is infective in level 1, and in level 2 and 3 you may have enlarged lymph nodes which are just big in size but are reacting to the node which is on top, because lymphatic is flowing in a particular sequence. from 1 to 2, 2 to 3, 3 to 4, 4 to 5, 5 to 6. Okay, that's how the lymph flows. So it may be happening that you have multiple lymph nodes in the neck where level 1A and B are malignant, but 3 and 4 are reactive. Okay, so it is just reacting to the chain which is there above them. Next investigation is ultrasound. Okay, USG of the neck. What does an ultrasound yield is the morphology of the node. Okay, when you see the node in a USG, you see the structure, whether it is ovoid, generally they are ovoid, the lymph nodes, or it is irregular. You check for any foci of necrosis within the lymph node. You check the integrity of the hilum and the vascularity around it. If the vascularity increases in a node biopsy, where if you have multiple nodes, you select one node depending upon its clinical characteristics and according to the clinical history, and you examine that into histopathology. That will give you a definitive diagnosis of why and what is happening in that particular node. This you do when you don't know what is happening to the patient. If a patient has a ulceroproliferative lesion in the oral cavity which has undergone an incisional biopsy and it has come back positive for squamous cell carcinoma, and the patient has multiple lymph nodes in the neck, you know it is generally because of that. Okay, but at times it may happen so that there is no oral finding, there is no systemic finding otherwise else, but patient still has multiple lymph nodes. In that cases, this helps, okay, because you don't know what is the primary cause. Miscellaneous tests, as I said, you can do some hematological testing in case of HIV. Okay, you may have sort of multiple lymph nodes that you will come through through ELISA test. Montague's test is for TB. You can even do a gene expert. And for dental examination abscess, you can take an IOPA, an OPG, a CBCT. Say you have an impacted third molar which had pericoronitis, it is long standard, you've developed a buccal and a pterygomandibular space infection, and you have an inflammatory node in the cervical area in 1B region. So that is an inflammatory node because of the infection. So you have to correlate whatever you see clinically. Clear? Great. So I will end this part here. Shantanu, can you please come? Where is the chair? Lights chalo karo. Shantanu, please, sir. Thank you. Okay, so before you begin any of your clinical examinations, it's always good to first introduce yourself to the patient. Tell them what you are going to do. You don't just start doing this to the patient, okay? It's not ethical. The patient needs to be aware what are you going to do and where are you going to touch him. You are not going to like if somebody starts touching you anywhere, right? So please make sure you introduce yourself to the patient. Patient knows what you are doing and why they are doing that, because it is their right to know. And only then they will comply and take the posture in which you want them to be and be at ease to let you do that particular examination, okay? These soft skills are very, very important. Okay, Shantanu, thank you for volunteering. I've already briefed him before the session of what we are going to do. First and foremost, always, if I see anybody doing all these examinations without gloves, you know how we punish them. Please do not do that. Always wear gloves. Imagine the patient has some systemic comorbidity and you don't know, and you start palpating them all over. It is not healthy for you and you are actually causing more damage. Okay? Because if there's an abscess somewhere here and you keep touching them, you are inoculating that everywhere. If it's a malignant lymph node which is draining out, you may be seeding those small cells somewhere else as you keep touching them. Okay? So please don't do that. So Shantanu, right now we will just be examining the cervical lymph nodes. Okay. So basically you don't need to draw anything. Right now I'm just drawing so that you all know what are the anatomical landmarks. First and foremost, make the patient sit erect in a comfortable position, hands on the lap. Generally you stand behind the patient. Shantanu, can you just go a bit lower? Just take the chair down. He's quite tall for me. Okay, fine. Thank you. All right. You have to be behind the patient when you start palpating. Okay. Make sure the patient is relaxed. To palpate the lymph nodes, you need to make sure that the patient is looking on the opposite side from where you want to start palpating. So what you have to do is ask the patient to look left. Shantanu, can you look left? Making sure the ear is over the shoulder. Okay? So as soon as you do that, what happens is my sternocleidomastoid muscle edge becomes very prominent. Okay? So I'm just going to mark some areas so that you understand where I am. Okay, this is my mandible. Okay. Right now I'm palpating the anterior edge of the sternocleidomastoid muscle, which is somewhere here. One second. Shantanu, yeah, just look that side. Yes. Okay, it is here. This is the anterior border of the sternocleidomastoid. This is the posterior border of the sternocleidomastoid. And this is the anterior border of the trapezius muscle. Okay, this is the trapezius muscle. This is level 5A. This is level 5B. Okay, look up. Okay, this will be my anterior belly of dry gastric to the hyoid, and this will be my posterior belly. Similarly, this will be the anterior belly of the other side. So this is level 1A. This is level 1B. Okay. Level 2, somewhere near the hyoid. Cricoid cartilage is just below the thyroid notch. So level 3, level 4. 5A and 5B are on the posterior aspect of the sternocleidomastoid muscle, and anteriorly is level 6. Clear? Everyone clear? You don't need to draw this on a patient, but this is how you need to basically understand. How do you go about doing that? Then what you have to do is, when I'm palpating the level 1A and 1B, you go behind the patient. You primarily use your index, middle and the ring finger for palpation. The pads of the fingers, okay? You use the pads. So what you do is, Shantanu, can you just look towards the left? You make sure that the patient is looking towards the left and little downwards, okay? And then you start palpating the submental area. So what you do is, with the fingers, you move the tissue or the node, if it's there, against the inferior border of the mandible in smooth circular motions. Okay, don't do something known as pianoing or spider fingering. That means what? You're not playing a piano. Okay, you're not a spider going creepy crawly on the patient. With 3 fingers against the submental area, you do a circular motion, try to palpate. 1B. Similarly, try to palpate against the inferior border of the mandible. Okay, once that is done, look left. What you do is you come along the anterior border of the sternocleidomastoid muscle and you start palpating. If there are any nodes palpable in level 2, level 3 or level 4. Okay, so we started here, came here, went down here, then you go posteriorly, feel the anterior border of the trapezius muscle which I have marked, and between the posterior border of the SCM and the anterior border of the trapezius, you start palpating for level 5 group of lymph nodes. Okay, when you come up till the mastoid process here or just behind the ear, here you can palpate for retroauricular group of lymph nodes, and behind, if there are any occipital group of lymph nodes, if they are palpable. Okay, also you can palpate any preauricular lymph nodes if they are present. Clear? Any doubts in this clinical examination? It's very simple. Okay, you start by standing behind the patient, looking on the opposite side, ear over the shoulder, level 1A, level 1B, along the SCM, 2, 3, 4, downwards, go upwards, 5B, 5A, postauricular, mastoid. Clear? Great. Thank you, Shantanu. Now going on to the next. Everyone understood, guys? Very simple, just remember the steps. Now going on to the next system, that is assessment of the temporomandibular joint. But for them, there is level 7, there is level 8, 9 and 10 also. But for your things, level 7 is basically somewhere near the supraclavicular area and the suprasternal space of bones. Okay, those nodes are generally involved in gastric malignancies. Okay, primarily if you have a lymph node that is palpable just near the clavicle in this area, they are indicator of a GI malignancy. For head neck, 1 to 6 is comprehensively. Ma'am is asking why somebody has to bend. Anybody? She's asking that question for you. Yes, Nehal. Why do you ask the patient to look on the other end? Or bend? Can you repeat that so that everyone can hear? Just repeat on the mic. Go ahead.
If we ask the patient to bend, so the muscles over contralateral side, the ipsilateral side over there are relaxed, and there we palpate against the inferior border of the mandible, so that exactly we'll be able to feel the enlarged lymph nodes. But if the patient's neck is stretched, we won't be able to palpate it as exactly because the skin over there is not relaxed.
Okay, just to put it in a nutshell, when I'm looking this side, which muscle is getting prominent? Which I want it to be, because I'll be palpating lymph nodes below that. When I'm doing 1A and 1B, all my suprahyoid muscles, when I'm looking this side, are stretched. So these muscles will not let me reach here. So when you look a slide down, they become, the length decreases, it becomes easier for me to palpate. That's the only reason. Okay. Now going on to clinical assessment of the temporomandibular joint, just brushing through, our learning objective would be firstly to identify where the joint is. Does anybody know where the joint is? Where is the joint? Everybody started. Great. Perform a comprehensive assessment, then again see what investigations that we need to do. So an overview of the TMJ, it comprises of the bony entities, that is the glenoid fossa of the temporal bone and the condylar process of the mandible, which articulates there. It is supported by an articular disc. Okay, this is the articular disc which is present between the two articulating surfaces, between the glenoid fossa and the condyle. You have the lateral pterygoid muscle, where one head engages into the neck, other one inserts into the pterygoid foveae in the neck of the condyle. This disc divides the joint into superior and inferior compartments. Okay. Along with that, you have a capsule which envelopes the entire joint, and various other ligaments which support the structure of the joint. Okay, so you have bony components, you have muscular components, you have an articular cartilage, you have a capsules, and you have ligament. Okay, so as you just hear, it's a very, very complex joint to begin with. The scope of this lecture is not to teach you anatomy, but to teach you the clinical assessment, for which some revision is essential. Now, what are the movements of the joint? What is the function of the temporomandibular joint? Now, what is this? Articulate, don't show me this. What is it? What is so special about this joint? It's known as glingmo-arthrodial joint. Why? Because it has two movements. One is a rotation movement and one is a translation movement. Does anybody know when the rotation occurs and when translation occurs? When you open your mouth. How much is the normal mouth opening? Sorry? 35. They are only saying 35. Sorry? You can say it's fine. Somebody said 35. How many are saying 30? How many are saying 40? 45? 50? 55? 60? I'm not bidding something here. Okay, it's a range. Always remember, any values in literature, any values to do anything with humans will always be in range. No two persons are similar, right? Everybody is different in their own ways. So there's always a range. So a normal mouth opening is 35 to 50. Okay? 35 is on the lower side, but if you see, they've divided it as per gender also. For women, I don't know why it's less, but I feel it should be equal for both. But still, literature is quite skewed. But basically, that's what you need to know. So when you start opening your mouth, for the initial 20 to 25 millimeters, there is only rotation of the joint. Okay, there is only rotation when you open. After 20 to 25 millimeter is when the condyle translates along the slope of the articular eminence. Clear? You all can do later. Okay, you won't be able to see this. Now for assessment of the temporomandibular joint, during my days of studies, I had made this mnemonic. It's called IP Roma. Okay, IP Roma. So what is this IP Roma? It is basically inspect, palpate, check for range of motion, opening, deviation, occlusion, movement sounds and auscultation. Okay, it's called IP Roma. If you just remember it, you know what to do. It's not entirely in sequence, but something that you should look for a comprehensive TMJ assessment. Okay, everyone clear? So when you inspect, this again I will be showing you on Shantanu, okay, step by step, what are you supposed to see. But you just need to know a few brief things. I'll just breeze through this. So first, when you inspect a patient, you have to look for facial asymmetry or facial symmetry. Ideally, should it be same or different? Both sides of the face? Great. If there is some swelling here near the preauricular area, there will be asymmetry. Correct? If there is, if a patient has ankylosis or he has a fracture, or if he has growth of one side of the condyle more than the other, there will be a little bit of asymmetry. So you look for any swelling in the preauricular area, and then you start looking at the chin, whether the chin is in the midline or no. Any deflection in the midline gives you an indication there is something wrong with the mandible or the joint in that area. Okay, so that's the first thing you check is asymmetry, preauricular area. Okay, that's the first thing you see in a patient. After that, what do you see is the mouth opening. Okay, you ask the patient to open the mouth. Now there are very different things that you can see in this. First is you check for maximum interincisal opening, means how much is the patient able to open their mouth by themselves. Okay, then you have something known as assisted mouth opening, means if the patient is opening until 25-30 millimeters, you try to open the mouth more, it opens another 10 millimeters. So then assisted mouth opening becomes 40. Instead of 20, it becomes 40. Then you check for termination, means once the patient has kept the mouth open, generally if I ask you to keep a mouth open, you will keep it open for some time, right? Some patients with any TMJ deformities or internal derangement will immediately close their mouth because it pains, it's painful. Or in certain conditions like ankylosis or trauma, patient may not be able to open the mouth. Okay? So the second thing you do while the patient opens their mouth is you check for any deviation. Okay? Whether the mandible gate is straight or no. Generally when you open your mouth, the mandible has to go down and up. In abnormal conditions, it will go right or left and then come in the midline, or it will just go on one side. Okay, so that is something for you to check. You check for the hypertrophy or atrophy of muscles. So basically you look for the masseter muscle here, you look for the temporal muscle and the pterygoid, medial pterygoid muscle. I will show you all on Shantanu. You check whether there is any enlargement or disproportionate areas of swelling in those areas. Because if one patient is using one side of the mouth to eat or to do some, some parafunctional habits on that side, patient will have hypertrophy of that particular subset of muscles. Then you go in for extraoral and intraoral assessment. For extraoral palpation, generally you do an extraoral palpation, you do a intra-auricular palpation. We will speak about everything, and then you also do palpations of muscles of. I think switch on the. Okay. First, what I told you is always firstly you check for symmetry. Okay. Okay. Glenoid fossa. Okay. Always try to use a scale. After that, what you do is ask the patient to do lateral excursive and protrusive movements. Okay. Can you see? So how you measure this is take the maxillary midline, mandibular midline, the central incisors, take a scale, move it to the right, and then you can measure with the scale how much is the deviation. Same thing with left side lateral excursive. Can you do a protrusive movement? And then you do a protrusive movement. Okay? Everyone clear? Right now we are only inspecting. We have not gone in for palpation. Okay? At this particular time, whenever the patient is opening or closing the jaw, you can at times hear audible clicks is what you need to look for or listen. Okay? You may hear something popping in inspection as well. So look for that. After the symmetry has been done, preauricular area, muscles of mastication, maximum mouth opening, assisted, unassisted, pain-free, lateral and protrusive movement is when you go in for extraoral palpation. Okay? Now extraoral palpation basically starts with palpating the temporomandibular joint, which I showed you is present somewhere here near the tragus. So what you do is you keep your finger, you stand in front of the patient, you keep your finger just in front of the tragus bilaterally and ask the patient to again open the mouth slightly. Can you open? Okay, now I can feel the condyle rotate and translate at the pulp of my finger. Okay, and when I'm palpating, what I'm doing is trying to make sure that both the movements are symmetrical. It's not that one side is sliding first and then the other. So you're looking for bilateral synchronous movements of the temporomandibular joint. At the same time, open, I am palpating the lateral pole of the condyle. I'm just pressing it in gently to elicit pain. If that pain is positive, that means there is something wrong in the joint. Okay? Generally, there should be no pain. So you palpate the lateral pole of the condyle. Okay? Secondly, keep your mouth open. Once the mouth is open, what you feel here is a little hollowing near the preauricular area, right here. Because what has happened is that the condyle is translated anteriorly. Now what you can do is you can take your finger and go behind the condyle and just press in this area. If there is pain here behind the condyle, means there is retrodiscitis, means the tissue near the posterior part of the TMJ disc is inflamed. So that gives you a differential diagnosis of what can happen. Clear? After that, what you do is you take your two little fingers and you put it in the ear like this, and then you press it ahead. Why? Because the posterior aspect of the pterygotympanic fissure, that is this area, posterior part of the pterygotympanic fissure forms the anterior wall of the external auditory canal. Means both these things share a wall. Okay? Both the joint moves, you can feel the vibrations along the anterior wall of the external acoustic canal. So open, close. So when he does that, when he opens and closes, you can just press that area. Now again it gives you an idea of the status of the retrodiscal tissue in that side. Clear? Everyone? Great. After that, you go for palpation of muscles of mastication. You start with the temporal area. I'm not going to shave his head to show you where the muscle is. So generally the muscle is a fan-shaped muscle that goes like this. Okay? Starts from the coronoid process here, inserts here, and goes along the superficial temporal line, and it inserts into the coronoid process here. So what you do is you divide this area into anterior, middle and posterior. Clench. You ask the patient to clench and then you start palpating these areas. with 3 fingers again. Is there any pain on palpation, or if you feel any nodules within the muscle? A nodule in a muscle is suggestive of a tension point in the muscle. Okay, a tension point or a trigger zone within the muscle which is causing the pain. So you palpate temporalis, clench, you palpate the masseter in its insertion, middle and origin. Okay, origin from the zygomatic arch, body, insertion into the ramus of the mandible. Everyone clear? Medial pterygoid muscle, you palpate just below the angle of the mandible. I can show you here. This is the mandible that we marked. So the medial pterygoid muscle inserts here is where you palpate here. Okay, within. There is another technique of bimanual palpation I will show you when we go intraorally. Clear? Lateral pterygoid is left to palpate, which we will palpate intraorally when we do an intraoral assessment. Open a mouth. In case the patient is unable to open the mouth beyond a certain threshold, how do you open it for him? Is by doing something known as a scissor technique. So what you do is you take your index finger and thumb. Everybody knows the Korean heart? Very good. So what you do is you keep your index finger here, thumb up, and then you open the joint like this. So that's another use of your Korean heart, is to open the patient's mouth. Clear? This is how you open the patient's mouth. Okay? And when you're opening the patient's mouth, you may feel a little resistance, but you may be able to push it beyond. That is a soft end feel, means you are still able to open. At times you feel a very hard stop, that is known as a hard end feel. Okay, so you should not go beyond that. So it can be either a soft end or a hard end field. After this, you of course check for occlusion intraorally, whether it is class 1, class 2, is there any premature contact, if the patient has any restorations done, is there a high point, you rule out all those things as well. Oh, can you open your mouth, Shantanu? Now what you do is, now I am palpating the insertion of the temporalis muscle onto the coronoid. So what you do is, you put your finger into the vestibule, go posteriorly along the coronoid, along the anterior border of the ramus, onto the coronoid. Okay, onto the coronoid, and you palpate your finger there. Patient may get pain there also, that is known as tendonitis. The muscles of, so what happens is, the temporalis muscle inserts into the coronoid here. So that's where you palpate it intraorally along the coronoid process. Okay. Once you have reached there, what you do is, can you just open your mouth? Okay, now close. You slip your finger and turn it towards the maxilla. Okay, and you go the way you go for a posterior superior alveolar nerve injection. You go upward, backwards and inwards, and you try palpating the lateral pterygoid muscle here. Okay, this way. And ask the patient whether there is any pain on palpation or no. If the patient, open the mouth, if the patient opens the mouth during this, it obliterates the buccal sulcus and you will not be able to palpate. So hence make sure the patient is biting down. Now another technique for palpating medial pterygoid muscle is, Shantanu, open your mouth. You take your finger, okay, preferably you can put some topical anesthetic, and you go lingually downwards near the inferior border of the mandible with one finger here and one finger here, and then you try to touch both your fingers and you try to palpate the medial pterygoid muscle. That's how you palpate your muscles of mastication. Clear? Any doubts? And that's how you palpate TMJ. Thank you. Thank you, Shantanu. Okay.
For the wonderful presentation and demonstration. I welcome you all for the last lecture for the morning session, where we will focus on a vital but often underappreciated diagnostic tool in triple O, that is the hemogram. In the realm of triple O, where we deal with a wide spectrum of conditions from inflammatory and infectious diseases to systemic disorders with oral manifestation, the hemogram serves as an essential baseline investigation. It is a simple, cost-effective, widely available, and yet incredibly powerful when interpreted correctly. As we begin this session, let us remind ourselves that every number on the hemogram tells a story. A story that when interpreted with a clinical insight, it can transform patient care and save lives. I encourage all of you to engage actively in today's discussions and demonstrations. Let us use this opportunity to deepen our understanding of how a routine investigation like the hemogram becomes a powerful diagnostic aid in oral pathology. I welcome young dynamic pathologist Dr. Vrutika Shah, who is an assistant professor in the Department of General Pathology, MGM Medical College and Hospital, Navi. I request respected Dean Ma'am, Dr. Shrivali Natarajan, to felicitate Dr. Vrutika Shah. Dr. Vrutika Shah is working as an assistant professor in the Department of Pathology at Mahatma Gandhi Mission's Medical College and Hospital, Kamote. She has pursued both her undergraduate and postgraduate studies at the same institutions. She has also worked as a senior resident in MGM Medical College and Hospital, Kamote and MGM Hospital, CBD, Belapur. She is also appointed as a blood transfusion officer at the MGM Hospital, CBD, Belapur. She has been a ICMR sub-coordinator for Phase 2 STS projects. Her areas of interest include histopathology, hematology, and quality assurance. She has a teaching experience with 2 years of undergraduate teaching and 4 years of allied sciences. Also, ma'am has 10 publications in national and international journals to her credit. She has also been a principal investigator in the ICMR STS projects. She has also delivered oral and poster presentations in various international and national conferences, CMEs and workshops. I request ma'am to begin with the session.
ये ना मैग्नेट है
हेलो हेलो
मैम स्लाइड चेंज करना नहीं लाइव के लिए
नहीं
हेलो
Hello, good afternoon. I would like to thank the organizing committee for calling me to deliver a speech on hemogram. So, without much ado, I'll begin with the session. Before I do that, I would like to ask you all, what is a hemogram? When it comes in layman terms, if you can describe it, or whatever your understanding of hemogram is. Anybody? Oral pathology is present over here, I'm sure. What is a hemogram? Somebody from behind is answering. I'm not hearing who. Okay, so I'll just go ahead. Hemogram is nothing but a complete blood count. Like, just break down the term, hemo and gram. We are looking at the assessment of all the blood cells as well as the plasma which is present in the blood, right? The blood components. Anyone knows the blood components? I'm sure. An easy question again. Yes, RBCs, WBCs, platelets, and plasma, right? So we are breaking down that session into different parts, what we will be going forward with. Okay, so we are just going with each and every cell to clear up all the... Now, we know for a fact that every patient that comes to us, there is one test that we do as a routine investigation, whether to assess the patient in its present state, and that is a CBC, right? So CBC is nothing but a hemogram. It is that routine that it's now become a backbone of any lab evaluation for any patient, okay? So following that, there are certain parameters that we study with regards to it, as I've already said, regarding the blood components. But it all began at some point for us, and that point was 1953. It happened with Coulter. So Coulter is a scientist who basically gave a principle to us where any fluid with particle, when passes through an aperture, when we pass a beam of light to it, it will move towards an electrode, which will be an anode or a cathode, okay? When the beam of light goes onto that particle, it is going to scatter light, okay? That will give us an assessment of what kind of a cell it is, the size, the morphology, granules, etc. of the cell, okay? And that principle to date has been used in each and every instrument that has come along as a hemat analyzer for us. So looking at that, we started with, you can see a small photograph over here. This was the first hemat analyzer that was made, and then I'll show you what advancements we have come across now. Before that, there are two principles in the Coulter principle, as I described in a very small, short way, but let's go into detail, where there's an electrical impedance principle. Now, what is that electrical impedance? When you are seeing this whole point over here, this is nothing called as an aperture, okay? The blood sample with fluids will be diluted so that each cell passes through this aperture. When it does, it will be charged. It will go towards a cathode or an anode according to its charge. Every cell particle has a charge on it, right? That charge will go through processors, okay? Amplifiers and processors, which will give us a graph. The machine will now interpret the graph to form wavelengths for us, histograms, scattergrams, etc. And they will, the automated analyzer itself will calculate these things and give us a reading. Okay? Is this understandable? The electric impedance? Right? So we'll go ahead with the next one, which is nothing but optical scattering. Okay? Next principle is optical scattering. I know that the diagram is a bit difficult, but here I'll just go on. This center part is what you have to focus on. Okay? Once it's going into the channel, that aperture, as I said, it will be mixed with certain fluids. Okay? Those fluids will contain some fluorescent dye to it, which attaches to the cell depending on its properties. That fluid, when passing through that aperture, laser beam is falling on it. With its properties, it's either going to scatter the light in 3 different directions. Okay? We have a forward scatter. FSC is nothing but forward scattering of cell. It will go onto a mirror where it will form a side scatter. Okay? That forward and side scatter of these cells with SFL, which is nothing but again side fluorescent scatter, will be projected onto a curtain or onto a plate which is present in the machine. That plate will reflect it and analyze it and form this scattergram which is formed over here. Okay? So combining the two principles, we have now combined and formed one hemat analyzer. Okay? Next one, coming to the equipment. Here to know, we have 4 different versions of these equipments. We have a 3-part, 5-part, 6-part and a 7-part. To understand it, it's very easy. Let's just focus on 3-part and 5-part first. Can you see the small machine over here? This is nothing but a 3-part, okay? Now, with this small machine, as its size is very compact, understand that it is analyzing less number of samples and it's occupying very less space. So the kind of labs that uses this machine, 3-part machine, will be the labs which have samples of less than 50 blood samples, okay? What it does is that it's going to analyze my red blood cell count and platelet count adequately. But when it comes to WBC, it can only differentiate the 5 different WBCs that we have neutrophils, eosinophils, basophil, monocyte, and lymphocyte into only 3 different types. How? Granulocytes will be identified as granulocytes. The monocyte, basophil, and eosinophil will be counted completely as monocytes or mid cells. And the last one, lymphocyte, will be identified as lymphocyte. So now the work is incomplete for us, and we require to see a slide when a 3-part comes into place. Okay? So when we see the slide, only then can we give a differential count to the patient. But coming to the next machine, which is the advancement on 3-part, called as a 5-part analyzer. Now this 5-part analyzer is doing one step further. Whatever deficiencies were given by 3-part is covering that up by giving me a complete differential as neutrophil, basophil, monocyte, eosinophil, and lymphocytes. Understood the basic difference between a 3-part and a 5-part? The name of 3-part has come from 3 differential, 5-part from 5 differential. Okay? Now we'll go one step above. We can't leave it at 5-part. So we have to add on to certain other assessments of blood samples where we take into place immature granulocyte. Now this is nothing but the cell differentials that gave us were of mature cells. Obviously there in some conditions, leukemia reaction, fever, any other malignancies, there will be a left shift to the cells where immature cells will come into circulation. And in that case, the 6-part will give me a differential count to the IG also. IG is nothing but immature granulocyte. Here a percentage is given to us, that these many percentage of immature cells are present in the blood sample. 7th part does the work of a 5-part and a 6-part. Add on to it, we have reticulocyte count, or we also have immature platelet fraction that can be counted by the machine depending on what reagent we put in. Okay, so this is machine and this is the principle. Let's go to the next part of the session. This is a hemogram. As you can see, I'll tell you this one is of a 5-part machine. Here what happens is we can list over here so many parameters from that blood sample. Whereas a 3-part machine will give me a cutoff right here and it will not count my differential completely. This is just an example of how a printout of a hemogram comes into place, what we assess and how we look at the blood sample after. So overall, the parameters that we generally need to assess a patient are RBC count, WBC count, platelet, hemoglobin, reticulocyte count, MCV, RDWCV, DLC, and PDW. Now they are derived from something called as hemograms, which I'll come to that later after the calculations are done. And we have calculated parameters like hematocrit, MCH, and MCHC. Okay? So next session, I would require all of you all to use your notepads. We're coming to riddle of blood. Okay? I'll be giving you certain parameters, certain cases. Please assess the blood sample as you have been given and give me a diagnosis. Okay? I'll pick anyone from the audience for this. Okay? The first one, first case, where hemoglobin is 9.5, total RBC count is 3.2, MCV is 87, MCH is 29, MCHC is 34, RDWCV is 17. Okay? Total count 4,900, DLC are within normal limits, platelet 1,96,000. MPV is 8.4 femtoliter. Can anyone give me a diagnosis for this case?
Patient is anemic.
Normal values. Okay. Sorry?
Anemia.
Anemia. Who's this? Please stand up. Oh, sorry. Thank you, sir. So yeah, this is a case of anemia. To explain this now, what we'll do is we'll go through the normal values. A female patient and a male patient have different hemoglobin value RBC count. Okay? When it comes to hemoglobin, for a female, we take it as, anyone knows the normal value?
11 we consider as normal.
12 to 15. If pregnancy, we take 11. Yeah, and males, we generally take 13 to 16. Yeah. So, looking at that, first thing, look at the hemoglobin value. It is 9.5. Less, right? Less than 12. It can be for male or female. So I know for a fact this is anemia. Anyone knows the definition of anemia? Sorry? Loss of hemoglobin. Yes, somebody told me oxygen carrying capacity of blood. So hemoglobin is the binding factor for oxygen to be present in our body, right? Anemia is reflection of that is reduced oxygen carrying capacity of blood. Now this is, you can think that it can be because of hemoglobin, it can be because of red blood cells also. But it's mainly because of the hemoglobin, because even if red blood cells are present, if the hemoglobin is less, the patient is going to present with anemia, because that is what is binding the oxygen to it, right? So coming to that, the first part that we saw, 9.5, we know that this is an anemia case. Now there are certain causes for these anemias to come into picture. It can be because of nutritional deficiency, it can be because of blood loss, and it can finally be because of any systemic disorders. All of these reflect onto the type of anemia that is present. Now to know that type of anemia, we require 3 particular conditions to be present. So I'll just start with that interpretation part, decoding the hemogram, before we begin with the riddles. So when we look at the hemogram, what we do is basically first look at the HB count, which when I showed you the parameters, I went back to it and I saw the HB value first. Looking at the HB value, is it within normal limits, is it less or is it more? Okay, there are different conditions causing all of these formation. To know one thing, low hemoglobin is anemia, but we have iron deficiency anemia, vitamin B12 anemia, there's some hemoglobinopathy called as thalassemia, and sometimes there's normocytic normochromic anemia caused due to any blood loss or because of any deficiencies in the sense of any bone marrow failure syndromes. We'll come into that in detail. After we look at the hemoglobin, what we do next is look at the MCV parameter for the cell. To know what is MCV, anyone knows the full form? Mean corpuscular volume. That is nothing but basically what of the blood cell? The size of the blood cell. What is the volume? The size of the blood cell, okay? Then we look at MCHC, which is mean corpuscular hemoglobin concentration. That is the amount of the hemoglobin which is present in that particular red blood cell. We are taking one blood cell in account over here, okay? Then we look at RDWCV, which is called as red cell distribution width. Now, RDWCV stands for coefficient of variation. When RDWCV is spoken about, it is basically a graph. As I told you in electrical impedance, a graph is plotted, right? So graph is nothing but plotted by all the red blood cells which are present in that blood sample. It gives me a graph, and RDWCV is the area under the curve. And that is what comes as a percentage to be, okay? Lastly, when we are looking at the RBC parameters, we check something called as a rule of 3. Okay, we'll discuss this in detail next. Just remember this checklist. First it's hemoglobin, followed by MCV, followed by MCHC, RDWCV, rule of 3, and then we look at reticulocyte and WBC platelet parameters. Is this clear to the approach? Coming to the red blood cell. So, there are conditions where we have low levels, high level. Normal level, we know it's not an anemic patient, right? Then we are looking at different other parameters which are present. Low hemoglobin will be in presence of low intake or absorption, menstrual bleeding or blood loss, and cancers or chemotherapy, to name a few. There are multiple causes of low hemoglobin. But for a high hemoglobin, we have only certain conditions which result in it. And one area of interest for you all is smoking. Patients might become, quite a bit of patients might be coming for oral cancers with a history of smoking, right? These patients will a lot of time reflect with a high hemoglobin value. Okay? This is nothing called as a secondary cause of polycythemia. Polycythemia is nothing but increase in hemoglobin count. Okay, so high hemoglobin is seen in polycythemia vera, kidney, liver cancers, heart, lung diseases, or smoking. Mean corpuscular volume, as we described, it's basically average size of red blood cell, high when the red blood cells are larger in size and low when the red blood cells are smaller in size. So when they are smaller in size, as you can see over here, we call them as microcytes. Okay? Microcytes. And when they are larger than normal, normal is what? Equal to small lymphocyte nucleus of 7 microns. If they're larger than 7 microns, they're called as macrocytes. Please register these terms. We'll implement it and you will have a better understanding once we apply it. Coming to MCHE, okay? Can you see these red blood cells over here? In a normal, hemoglobin is present in the periphery 1/3, right? Sorry, over periphery 2/3, leaving the central 1/3 in position. When it is more, then when the pallor is more than 1/3, we call it as a hypochromic red blood cell, which is seen with a less MCHC value. Okay? And when the red blood cells have complete presence of hemoglobin, now it will be with increased MCHC value. Okay? RDWCV, as I mentioned, is uniformity in the red blood cell size. Coming to a rule of 3. Okay, rule of 3, we take only 3 parameters to check whether everything, the machine has read it correctly or not. We look at hemoglobin, the red blood cell count, and hematocrit. Okay? Hematocrit should be 3 times that of hemoglobin. And when we look at hemoglobin, it should be 3 times that of the red blood cell count. In a normal patient, this will stand true. The minute there is an anemia or minute there is an abnormality with the red blood cell structure or morphology or its calculation, this rule will go out of proportion. So this is just an analysis at the start when we look at the hemogram whether it has read the patient correctly or not with its normal values. Okay? How did we come about this rule of 3? You all have heard MCHC. MCHC is the presence of hemoglobin in that particular red blood cell. That is derived by a formula. It's a calculated parameter, first of all. Machine calculates and gives us the reading. But how does it do that? It uses hemoglobin and hematocrit multiplied by 100. Hemoglobin about hematocrit multiplied by 100. Now in a normal patient, our MCHC value ranges between 32 to 36. Take an average, 33. With that 33, when I place it over here, okay, now calculate how much the hemoglobin should be equal to. So 33 over here will be gone here. 33 multiplied by hematocrit upon 100 will give me hemoglobin value. So this value will become what? So eventually we end up getting multiplied by 3 for hematocrit. You all can do this in your paper, the calculation for it. Tell me how to get hematocrit from this particular formula, assuming MCHC is 33. Okay, when you calculate it, it will stand through to this formula. My 100 goes down, hematocrit goes up, 33 divided by 100 becomes 3 over here. That multiplied by hemoglobin gives me my hematocrit. Got it? Understandable? So we are using MCHC as a parameter over here, right? So this formula eventually depends on my MCHC. It's giving me whether the MCHC is calculated correctly by the machine or not with the rule of 3. Coming to the next one, where we are looking at the hemoglobin value. How do we derive that value? MCH is equal to hemoglobin into 10 divided by RBC. Okay? Here we assume the MCH. What is the normal value of MCH? 27 to 32. Take MCH as 30 as average over here and find out how will we get hemoglobin. This is again coming to hemoglobin equal to RBC into 3. So with this second formula, we are assessing whether MCHC is calculated properly by the machine. So this stands true to the fact that we are evaluating the whole sheet that is given to us by Sysmex by just using this rule of 3, taking the 3 parameters, hemoglobin, hematocrit and RBC value. That's it. This is what you have to look at first. Okay? So how do we assess that anemia? We saw one particular photo where all the parameters were given to you. We showed hemoglobin to be 9.5. Okay? So we know for a fact it's anemia. After that, we look at the MCV, as I said in that sequence of order. This is in a scenario where my rule of 3 stands normal. Okay? MCV, when present, if it is less than 80, 80 to 100 is normal. If it is less than 80, it becomes a microcytic anemia. As I said, microcytes will be present, right? MCV is showing me the size of the cells. Okay? Then when we are looking at macrocytic, the MCV being more than 100, the size of the cell is larger. So we call it macro. Macro means larger, some larger cells. And then we have something where anemia is present, but MCV is within normal limits of 80 to 100. This is nothing but there we look at reticulocyte count. Now what are reticulocyte counts? Would anyone like to tell me? Oral pathology. Reticulocyte count, sorry? Somebody is whispering. Oh, reticulocyte count is nothing but it's a stage of RBC just before the mature cells are placed into the system. Okay? So what happens is, we have different stages where the nucleus of the red blood cells in the bone marrow starts dissolving. There will come a point where it is still immature to be released to be completely functional, but it will have lost its nucleus. Those cells are called as reticulocytes. Okay? The presence of this in the red blood cell with its value lets us know what is the status of the bone marrow. Bone marrow is the place where the red blood cells are made, right? So when the reticulocyte counts are present in the blood, it means the bone marrow is functioning properly. Okay? The minute it is increased in the blood, the reticulocyte count, it means the bone marrow is stressed and it's just pumping out the red blood cells into the circulation to compensate for whatever causes which reduce the RBC count. Okay? So reticulocyte now becomes important because think, normocytic anemia is generally attributed to blood loss in the system. When the blood is lost in the system, what happens to the bone marrow? It will work to replace it. When it works to replace it, it will increase the reticulocyte count in the blood. So as soon as we know it's a normocytic anemia, we have to look at the reticulocyte count for the patient. Okay? If the reticulocyte count are high, it means the bone marrow is working normally. Please look at other causes of normocytic anemia. And if bone marrow is not working properly, the reticulocyte count will be low. So now we have to look at the bone marrow causes. Aplastic anemia, if you have heard of it. Any leukemia can result in bone marrow failure. Okay? Is this flowchart understandable? Can you all assess the anemias that we come into, the cases that we come across now? Will that be possible by all? Okay, this is one case for you all to just assess yourself with whatever we went through right now. Okay, your RBC count. Is there some disturbance behind, please? Okay, we will go through this where RBC count is 3.3, HB count is 7.5, hematocrit is 25, MCV is 76. MCH is 22.7, MCHC is 30 and RDWC is 17.5. For ease of your reference, we have given this reference interval which is nothing but normal value. Okay? Now, will this be easy for you to assess? I would like one of you all to stand up and give me an explanation of this. We'll walk through it. Whoever doesn't understand can also volunteer. We'll walk through the whole pathway. Shall I pick somebody? Fourth bench, second goal. Sorry, I don't know your name. Yeah, you. Please stand up. Okay, you want to volunteer? What is the hemoglobin? Yeah, is it within normal? So what will we think of first? Okay, great. Please have a seat. Next step. What is the next step that we have to look at? MCV. Third row, third sitting row, second goal. Assess the MCV. It's normal. It's reduced. So what kind of an anemia will we look at? If it is less, we call it microcytic. Great. Sit down. Have a seat. For the next one, what is the next step in the flowchart, in the algorithm? MCHC. Anybody who wants to stand up and volunteer for this? Please stand up. Yeah. With the green bottle. Please stand up. MCHC. Assess it. Sorry? Reduced. So if it is reduced, as 32 and 36 is the normal, what will we call this as? Hypochromasia, right? So now what is the kind of anemia? Yes. So this is nothing but interpretation of the hemogram. Simple? Anything else that we need to look at? I'll tell you the significance of it now. RDWCV is the next step, right? What will it give me? It's 17.5. It's increased. What will be the interpretation of it? RDWCV, have a seat please, is nothing but it's the measurement of uniformity of the red blood cells. Have you all heard of different types of red blood cells? Normocytes, macrocytes. Macrocytes are the size of cells. Sickle cells, teardrop cells, schistocytes. Have you all heard of these kind of cells? Right? When they are of different shapes, different sizes in the blood. Okay? So what happens now, when it's going through the machine is not able to identify it as what kind of a cell exactly, but it will calculate it and give it different sizes to me. So what will happen, the graph which is supposed to be bell-shaped with a small peak to it between 80 to 100 will now be broadened, and it might start at 50 and end at 120. Why? Because of the different shapes of the cells. That measurement is RDWCV for me. Okay? So it is a measure of anisocytosis. Anisocytosis is defined as the change in the shape of the cells. Okay? So if I'm having a lot of microcytes in the blood, then it will give me a peak when it is, the RDWCV might be within up to 26. Why? Because the microcytes of different shapes will be present. The graph will be enlarged, elongated. Okay? So this is where I'm talking about the graph. Now, can you see there is a peak present over here, right? How do we plot a graph? X-axis and Y-axis, right? We take parameters that we want to assess. Over here, what we do is, this is the number of cells present on the Y-axis, and on the X-axis, we measure the MCV of the cell. MCV is the size of the cell, okay? So here, it's supposed to start at the baseline. it will go and it will have a peak and it will go down. Can you see these dotted lines in between present over here? These are nothing but we are giving it a discrimination. We are dividing it as 50, 100, 150, 200 and 250. Can you see a 250 over here? Right? So this dotted line is 50. Second dotted line is 100. Third one is 150 and fourth one is 200. So what will happen over here? My blood cells have been they start assessing, okay? I'll get one blood cell which is of 80 femtoliter. It will go and plot itself over here on the graph. The machine will plot it for me. If my red blood cell is of 10 femtoliter, just an example, it will plot itself somewhere over here, okay? So multiple red blood cells will be present. For each red blood cell, it will give me a count, the size of it, and it will form a graph over here, okay? This graph is called as a histogram. For RBC, it is a RBC histogram. This peak present, now it's at 100 for me, right? Can you tell me what kind of an anemia will this patient have? Majority of my red blood cells are present at 100 femtoliter. The second line is 100. 100 femtoliter is nothing. Region, whereas large red blood cells like macrocytic cells and RBC agglutination will give me a graph over here. What is an agglutination? Clumping of red blood cells. So it's going to form one bunch, right? So when it forms a bunch, it will be larger in size than 100 femtoliter. That's why it's plotted right at the right upper threshold of the graph. Okay? Coming to platelets, okay? So platelet normal range, anyone is aware of? 1.5 to 4.5 lakhs. 5 in some labs depending on the reference interval. Now here, tell me what can be the causes of low platelet count? Very common, dengue somebody said, very good. Anything else? Sorry? It's there on the screen for you to see. Malaria, common for right now, right? So low platelet counts come in those scenarios. Those patients are going to come with fever and chills to us, okay? Anything else? There are certain conditions where the bone marrow doesn't produce the platelets up to the mark, okay? Examples, immune thrombocytopenic purpura, right? Anything else? If there's a malignancy, what will happen? Malignancy starts in the bone marrow, hematological malignancy. Those cells, when present in the marrow, the malignant ones, you know it has a tendency to proliferate, referring to the chapter of neoplasia. When they proliferate, it's going to cause the other cells to stop working. So it's going to cause the erythroid series to stop working, so RBC won't be produced. Platelet series to stop working, so platelets won't be produced. So malignancy is also an alert when it comes to low platelet count. Okay. Next, there are certain conditions when platelets are more than 5 lakh. What are those conditions called as? Thrombocytosis. So we have some cases where we have also seen this after some surgery. You might have also seen after some dental surgery, the platelet count might increase for the patient. Why? Depending on the blood loss, the platelet has to go and work on the bleeding site, which will cause the bone marrow to increase the bleeding, increase the production of platelets, resulting in thrombocytosis. This is nothing called as reactive thrombocytosis. But there are some hematological malignancies of platelets also, which cause increased platelet counts in the peripheral smear. That is called as essential thrombocythemia. Okay? These are nothing but words for you to register. The focus over here is to know what is normal and when to know it is abnormal. Okay? So when we looked at the RBC histogram, why shouldn't the platelet also have one, right? So platelet histogram is also produced by the machine, but there we do not have 50 femtoliter intervals for each, where one end was 0 and the other end was 250. We don't have that when it comes to platelets. In platelets, because the size of the platelet is so small, it ranges between 0 to 30 femtoliter. And it's going to project itself in a graph between that itself. Okay? So coming to the parts where it can be abnormal, again, it's a graph where it's supposed to touch baseline on both the sides. When it doesn't, it is an indication that there is some abnormality present in the blood sample, which can be in the form of artifactual abnormality like clumping of red blood cells. It can be breakdown of red blood cells called as fragmentation, which will present itself again in the starting part of the curve. Okay? Red cell fragmentation, any contamination by bacteria or platelet aggregation. When we are looking at the other upper side, if you can see the baseline over here is not touched. Here we are looking at what? A clotted blood sample, fragmented red blood cells, large platelet clumps. Because they are larger in size, that the machine cannot analyze and place it in the graph itself. So what? It gives me a curve which is going out of the graph. So we are looking at this and knowing that there is something which makes us see the slide, where we recommend peripheral blood smear for the patient. Coming to the white blood cell count. So you all saw optical scattering, right? Can anyone refresh that for me, please? Yes, please try. There is side scattering and yes, exactly, correct. So what happens is, red blood cell is aspirated. We mix it with some fluids where the red blood cells are destroyed. What is left behind is white blood cell. Now white blood cells are also given another stain to it, which is called as a fluorescent stain. Okay? Then you all know that there is prism pata hai na? One light ray, it will scatter into different colors of light. Same thing over here, it will scatter into different colors of light when the laser beam falls onto the cell. Why does that happen? We do not have a prism or anything. It happens because of the cell, the nucleus, the cytoplasm and the granules which are present in the cell. Okay, so a cell which has a proper nucleus to it and cytoplasm, will it scatter a lot of light? No, it won't. It will scatter less number of light, a clump nucleus. That's why NRBCs will be present here. But when I'm looking at a neutrophil, will it scatter? Yes, because the granules are very dispersed in its cytoplasm. So it scatters and it will present itself over here. It is still this way. The side scatter will be present. Okay? So to give it in a gist, each and every cell of WBC, okay, will divide itself into different light scattering mode. Okay? Some cells will give me a forward scatter, which will be red blood cell, because they do not have a nucleus. So everything is the light just goes through it. But when it comes to neutrophils, lymphocytes, basophils, eosinophils and monocytes, it will give me a scatter of light. Okay? Some light, you all have experienced you all have seen that light scattering when the light goes through a glass, right? In some angle we'll get that rainbow, in some angle we'll just get light passing through. That is the scattering that we're talking about over here. Understood? So this is how it will place itself onto a graph in different areas. Okay? I'm not going much into detail, but now what I'm going to talk about is nothing but alerts that you get when the machine comes into place, and you know you cannot interpret anything with that hemogram. The places where we are not supposed to look at hemogram at all. Okay? We call them eclipses in hematology, where basically what happens, there are some malarial parasites. You all know that it's present in the red blood cell. Malaria, when it comes into the body, it is going to grow in the red blood cell. Now when it grows in the red blood cell, it is going to give granules to it, right? It is going to give a ring form to it. That will cause light scattering to happen. So those light scattering will happen and the machine will not be able to interpret the cells that are present. So when it does that, it will give me something called as a whiteout. Okay? This whiteout should give you an alert that you have to see the peripheral smear. Here you have to you will have to ask for tests when it comes to this particular aspect to it. Then when see, this is what I'm talking about. This is a malarial parasite present in the red blood cell. Can you see these granules pointed by arrow over here? And this is one ring form present over here pointed by arrow B. This is what is going to give the scattering to present. Otherwise, red blood cell is not going to give me any scattering. It's going to be forward, go through, nothing. Okay? This will give that abnormality to the machine. Next is when NRBCs come in place. Sorry, these are atypical lymphocytes. Now, some lymphocytes are within normal limits, some are abnormal structures to it, which will again give different type of scattering, where the machine will not be able to interpret. Machine will interpret a side scatter at 540 nanometers, and it will assess, but it won't assess what is beyond 600 and maybe less than 400. Okay, so at those times, what it will do, it will plot me a graph, but with a white color. That these are the cells which cannot be interpreted by me. Please look at the peripheral smear. Okay. Coming to the next one, which is again nucleated red blood cells. Red blood cells forward scatter as usual because it doesn't have a nucleus. The minute it got the nucleus, it's going to give me a side scatter to it. Okay. Those side scatter will be plotted over here in the graph. Again a whiteout. You have to see the slide over here. Lastly, we have certain malignancies where blast cells will be present. Those blast cells cannot be characterized by the machine into anything because of its scattering again. So that will give me a whiteout. So anything white on your screen, please understand that you have to look at the slide. Leave the hemogram as it is, leave the printout as it is. Look at the slide and give your assessment according to the slide on it. Okay? So these are the different graphs, how it will plot itself in an acute myeloid leukemia, where patient comes with a bleeding tendency to us, right? Have you all seen cases of acute myeloid leukemia in your clinics or OPD? Coming with bleeding tendency, because they do come with bleeding gums. It's quite common for them to come. These are the whiteouts present. Then in chronic myeloid leukemia, we can see normal cells also, but it's still plotting an abnormal graph for me. So it is showing normal population of cells as well as abnormal population of cells, which we generally see in a chronic myeloid leukemia. There are certain places where we do not get the exact results on the machine. Those are clotted samples, clotting or cold agglutinins. In case of a WBC count might be spuriously low because there might be a clot present in the blood sample itself. And lastly, clotting of the platelets. The clots will hold on the platelets, giving me a low platelet count. Okay, so the machine, the take-home message is basically that the machine can do a lot of things for us, but it's not the only thing. We have to look at the slides as well. And I would like to acknowledge my mentor, Dr. Maheshwari, for this, for giving me this opportunity. Thank you.
Thank you, ma'am, for the insightful session and making the difficult topic a very easier one for us. Now we'll take a break for lunch. Please gather back after half an hour. And for the registered delegates, the lunch is arranged on 5th floor.
Thank you. Yeah, thank you. Yes, ma'am. Sure, ma'am. Hi, it was actually a very difficult topic. I'm so sorry I couldn't make it much simpler for the students because I tried. Okay, thank you. Thank you.
Even we also have a 5-part unit. We also have.
Yeah,
Here
yeah.
we have installed the 5-part only.
Right. So now it's basically, because there were some samples which used to come to central lab and we were running it on 3-part. Yeah.
And sometimes we have a difficulty also. Sometimes
Yeah.
then we have also come there only for
To
review
show.
the slides also.
Right. So I don't know.
I don't know because some other colleges they have a 3-part only, so it's better to you introduce the 3-part only followed by the 5-part.
Okay, right.
So currently they come because we have to this online,
Yeah.
so they have a 3-part only.
Okay. Right.
That depends on 5-part, 3-part. What is the difference also?
Yeah.
Chalo, madam.
Yeah, sure.
session. Those who are coming late, they will sit behind. You come forward. Come, come, come. We'll have a little fun. We'll have a quiz time now. We'll play quiz. The person who will give answer, they will get some benefit of it. Yes, chocolate. We'll give chocolate, okay?
The last time I'm telling now. Before I use my head, come in front. Come fast.
Okay, we'll start. Please raise your hand if you know the answer, okay?
Front means one lobe in front. What does front mean? Arushi, what does front mean? And you are not allowed to eat in the auditorium. Absolutely no eating in the auditorium. Absolutely no eating in the auditorium. I hope I'm clear. So you want me to call out names? Request is not enough.
Quiz, okay? Not any subject wise, it's just in general knowledge. Okay? Those who knows, don't prompt. Raise your hand, at least they will get a chocolate, okay? If you answer. If the answer is correct. Okay, we'll go. What is the long form of ID?
All cannot get no chocolate.
Praveen? Yeah, hang there. Hang there.
Praveen, camera की बैटरी चार्ज कीजिए.
Hello.
Isn't direct this one?
This one.
Can I say this?
Freeze करो ना, freeze करो.
Raise your hand. What is the long form of VIZ? Viz?
Anybody raise your hand?
Only one?
No, don't use mobile.
Don't use mobile phone, huh?
Visualization.
No. Any other?
Which is?
No.
Next category.
So vis is readily. Okay, what does it mean? It's a Latin term meaning namely. Okay, vis is namely or to wit. Okay, next question is, what is e.g.? Example given. Don't prompt. Please raise your hand, otherwise you will not get chocolate. Okay, that is wrong, but any other? No? Nobody's getting chocolate? Is example Gracia. Okay, next question. Do you know the long form of army? Anyone knows the long form of army? No? No one will get chocolate then. It's alert, regular, mobility, young. Okay, army's long form is alert, regular, mobility, young. Long form of navy, same. Anyone who knows? Nautical Army of Volunteer Yeomen. Okay, that is the long form of navy. NCC?
National Cadet Corps.
Correct. At least one will get chocolate. It's a National Cadet Corps. Long form of Wi-Fi? Hey, only one. Anyone knows long form of Wi-Fi? Check for behind. Praveen, tana mic dena. What is it? You raise your hand, na? What is it? Wireless fidelity.
Wireless
Fidelity. Correct. Okay, tell the picture present on the note, except Gandhi. What is the picture behind this note? Anyone? Please raise your hand. This is general knowledge. Everyone carries this note. Okay, tell.
Ashoka Chakra.
Ashoka Chakra. No. Sanchi Stupa. I'll check. What about you? Same Sanchi Stupa? It's Konark Sun Temple. Okay, it's Konark Sun Temple. Okay, what is behind rupees 20? All are on GPay, right?
Ellora Caves.
It's Ellora Caves. What is behind 50? No Google, huh? Who said Humpy? No, student. It's a Rath. Yeah, it's a Rath of Humpy. Okay? What is behind 100? अभी सब देख रहे हैं फिनिश यहीं पे फिनिश हुआ है इट्स रानी का वाव ओके दैट इज स्टेप 12 इट्स इन सॉरी सांची स्तूपा
Sanchi Stupa.
500. If you are prompting, you will not get. You have to raise your hand. Okay, what behind 2000? Chandrayaan. Wrong. It's Mangalyaan. Okay, this is for fun only. Okay, it's over. Okay, we'll start. We'll start our next session now.
Good afternoon, all. Good afternoon again to all respected faculty members, distinguished guests, dear students and colleagues. It is a great honor and privilege to welcome you all for today's session by Dr. Rohit Gadda, where we explore a key component in the diagnosis and management of oral diseases, that is the radiographic interpretation in oral pathology. In the practice of oral pathology, accurate diagnosis begins with careful observation, both clinically and radiographically. While clinical examination reveals what is visible to the eye, radiographs unveil what lies beneath the surface, that is the hidden dimensions of bone, teeth, and the supporting structures. Radiographic interpretation is not merely about looking at images, it is about reading patterns, understanding disease progression, and correlating findings with clinical signs and symptoms. It basically bridges the gap between clinical suspicion and definitive diagnosis. As future clinicians, oral pathologists, and dental professionals, developing strong radiographic interpretation skills is not optional, but it is essential. Dr. Rohit Gadda sir has completed his BDS from Sharad Pawar Dental College, Bardha, and MDS from Manipal College of Dental Sciences. He is currently working as a reader and HOD in MGM Dental College and Hospital. He has presented multiple papers and posters and has also been a guest speaker and chairperson for many national and international conferences. He is a member of editorial and reviewer board of national and international journals. He also has 22 paper publications in national and international journals to his credit. Also, he is the in charge of Tobacco Cessation Center at MGM Dental College and Hospital, Navi, Mumbai. Let us begin this session with open minds and sharp eyes. I welcome Rohit Gadda sir for the session.
कॉलर माइक घ्या ना सर हा एक लावा यूट्यूब ह्याच्यासाठी एक मिनिट ठीक आहे यूट्यूबसाठी हां तिकडे आवाज जाण्यासाठी
वो अंदर लगी
ओके फिर हाँ ये लगे ठीक है okay very good afternoon thank you Dr. Neelam for nice introduction I think we are going back to basics and we have maximum audience from third year so I will be covering mainly OPG and CBCT here okay it may be little bit higher for you all but all the landmarks anatomy is same what you see on IOPS
Our online audience is all
postgraduates okay fine so learning objective for today's session would be basic anatomy on OPG basics of CBCT and image displays on CBCT and clinical applications so we'll start with OPG. Can anyone tell me what is OPG? Orthopantomogram. So orthopantomogram. Its actual name is panoramic radiograph. OPG is one of the pioneer company. They came up with OPG. So it's a tomography. Can anyone tell me what is tomography? all of us are dealing with two-dimensional images, right? It's not 3D image. So tomography is basically imaging one slice within three-dimensional object by blurring out structures which are present above and below that slice. All of you might have taken panoramic views on your cameras, mobile cameras. So we get bird's eye view. Now, can anyone tell me how is this jaw looks like this in actual? Look at the lower jaw. Is it flat? It's horseshoe shape, right? So basically it is combination of two lateral skull views and so there are two lateral skull view and one frontal view, which is something like this, and these images are combined to come up with orthopantomogram, panoramic radiographic image. Okay, if you see OPG, it looks very easy to interpret. Yes, am I right? You can see all the teeth with third molars and dentoalveolar structures. I want answers from you all. It's easy for interpretation. Yes, it is very easy for patient education, but believe me, it is most difficult radiograph for interpretation because of lot of overlapping structures, present double images and ghost images. We'll be talking about those. Now here, can anyone tell me, look at this maxillary left first molar root in apical third. Do you see anything here? I hope backbenchers are able to look at this. Do you see some horizontal line here? Is it fracture? Root fracture or no? Maxillary left first molar. Look at the pointer. No answers. Still confused. Okay, anyone from PGs? Oh, it's actually not floor. Actually, this is, look at the image here. This is dorsum of the tongue. Shadow is casted over this. And above this, we have hard palate. Now, this is actually image capturing error. When somebody captures OPG, we generally advise, radiology technician will advise patient to touch the tongue to palate while taking the radiograph. Otherwise, these roots of maxillary molars become blurred because of this airway space between tongue and palate. So let's start with some of the anatomic landmarks. Now, can you tell me how many spines or vertebral spines we have in body? One or two? One, right? Anatomy, third years. But on OPG, we can see two image, that is double image of spine. Any structure which is present in midline will appear as double image on this OPG. Okay. Similarly, we have hyoid bone on both sides, but actually we have only single hyoid bone. So we'll come to next, earlobe. It's a soft tissue cartilaginous structure which can be projected on OPG. Then styloid process. Look at the styloid process on other side. Can you appreciate? So this is, sometimes there can be elongated styloid process. Have you heard of Eagle syndrome? Yes. So Eagle syndrome is basically calcification of stylohyoid ligament and can give rise to some kind of pathologies or symptoms for the patient. Next is hyoid bone. Zygomatic process of maxilla. All of you might have taken maxillary IOPA for maxillary molars. You might have seen molar roots are getting overlap with some structure, that is zygomatic process of maxilla. But in OPG, shadow of this goes upward over the maxillary sinus. Next is zygomatic arch in front of TMJ. Next, condyle, glenoid fossa and articular eminence ahead of glenoid fossa. Sigmoid notch between condyle and coronoid, and we have angle of mandible. Now this is ghost image. Look at the image here. Can you see one shadow here? Horizontal line. It is actually ghost shadow of angle of mandible on this side, getting projected on opposite side like this. So this is ghost shadow. Next, external oblique ridge. Nasal septum in midline. Next to nasal septum, can you see one airway space, radiolucent area? That is common, nasal meatus. Then we have walls of nasal fossa and common nasal meatus. Next, inferior turbinate, it's a cartilage. So it will appear gray shadow. This is inferior nasal turbinate. Then floor of maxillary sinus. Now many times within the sinus we can see some shadows of maybe mucocele or mucosal thickenings on OPG2. Then inferior alveolar canal. It exits at mental foramen in mandibular bicuspid region. Next, pterygomaxillary fissure. Now this is very important landmark in trauma cases. Basically in Lefort 1 or Lefort 2 fractures, this landmark will not be, you won't be able to appreciate on OPG. And that indicate, because there are very important neurovasculature passes through this pterygomaxillary fissure. Next, this is dorsum of tongue. We already discussed about this. Shadow of dorsum of tongue. Above that we have hard palate, and between these two, that is airway space of oral cavity. Coming to soft palate. So we saw this is hard palate, and behind that we have soft palate. Now what would be there below the soft palate? Some shadow here on both sides. That is oropharynx. Okay. Below that we have posterior border of the tongue, and between two we have airway space, that is oropharynx. Next is floor of orbit, and near floor of orbit we have infraorbital canal. So on panoramic radiograph you should be very well versed with these anatomic structures. Yes, dentoalveolar anatomy is very much clear, but because of other anatomic structures overlapping with this dentoalveolar structure may lead you to some kind of misdiagnosis. That should not happen. Now we'll be touching upon cone beam computed tomography, CBCT. Now why is it called CBCT? Anyone? Cone beam computed tomography? Because X-ray beam, shape of X-ray beam is cone shaped. Will not go in depth of all this. Computed, high-end computers are used to read the data set, 3D data set, and tomography. We already discussed what is tomography. Anyone? Imaging one slice from three-dimensional object. And structures above and below are blurred out. So this is cone beam computed tomography. Now all of us know it is three-dimensional data set or imaging. So obviously it will have more advantage over OPG or panoramic radiograph, which is two-dimensional radiograph with lot of superimposition. On CBCT we have no superimposition, no distortion. Now on panoramic radiograph we have slight magnification. Even magnification differs in vertical dimension and horizontal dimension on panoramic radiograph, whereas on CBCT we get true size images. Whatever measurements you do are of true size, and ability to create cross-sectional images. We'll be talking about these images in next slide. So basically, this is a patient. There is X-ray source and detector which rotate around the patient. With one rotation, whole 3D data set is captured. Now, to read this 3D data set, we cannot read what is there in between. So for that, we create multiple slices. That is called multiplanar reconstruction, MPR, in different anatomic planes. Now, all of us must be aware of these planes. One is axial plane. When patient is standing, it will divide body into upper and lower halves. Then we have sagittal plane, which passes through sagittal suture on skull vault. It will divide body into right and left. And third one is coronal plane, passes through coronal suture on skull vault and divide body into front and back. To understand these planes, we'll go through CBCT images. Now, any CBCT software will provide you this axial, coronal and sagittal section and one 3D image. Now, this yellow colored plane is axial plane. This green one is sagittal plane and this one is coronal plane. So we'll start with coronal section passing through frontal part of the skull, anterior most part of the skull. Look at this purple plane on 3D. So it is passing through nasal bone. We can see nasal bone and anterior teeth of maxilla and mandible. Let's go slightly backward. We are able to see nasal bone, nasal fossa, common nasal meatus and incisu canal. When we are moving through plane, look at the plane how it is moving backward, so that you will be able to localize these sections and will be able to know what can be anatomic structures there. Now here we have nasal fossa, sinus, maxillary sinus and mental foramen. If we go further backward, zygoma started appearing and we have maxillary sinus on both sides, which is more clear. Then zygomatic arch. We'll go further backward. Coronoid process started appearing. Then further backward we have sphenoid sinus and pterygoid plates. Now these pterygoid plates are present behind the maxillary tuberosity. We have medial and lateral pterygoid plate. Further backward, this plane is passing through condyle. So we can see TMJ condyle with its glenoid fossa on both sides. Further backward, we have vertebral column. We have odontoid peg of C2. Further backward, we have mastoid air cells on both sides of the skull. Now coming to axial sections. So observe this yellow colored plane which is present below the mandible. So below mandible we can see hyoid bone and vertebra. If we go upward, now this is anterior portion of lower border of mandible. Further backward we have mental foramen. Further upward, mandibular teeth started appearing. If we go further upward, maxillary teeth and lingual foramen on medial aspect of ramus of mandible on both sides. If we go further upward, maxillary arch, we can appreciate 3 roots of maxillary molars, mesiobuccal, distobuccal and palatal. Further upward, we can see pterygoid plate. Now we saw pterygoid plate in coronal section. This is how it appears on axial section, medial and lateral pterygoid plate. And this is ramus of mandible. Further upward, coronoid condylar process of mandible and maxillary sinus with pterygoid plates. Further upward, we have zygomatic arch started appearing. If we go further upward, zygomatic arch is completely seen. Now we saw axial and coronal plane. Here we can study anatomy in bilaterally. Now we have third plane, that is sagittal plane. In midline, sagittal plane, look at the 3D image. In midline we have sphenoid sinus, and above sphenoid sinus we have sella turcica. If we go laterally, maxillary sinus started appearing. Further laterally, we can see condyle situated within glenoid fossa with articular eminence, which is more clear on next slide. Okay, now these are three anatomic planes what we have studied in general anatomy. Now beauty of this CBCT is we can create our own arch and come to one panoramic radiographic slice without any kind of overlapping. For that, we can draw the arch, select one axial section, either for maxilla or mandible. In this case, it is shown in mandible. Axial section is taken at the level of roots of mandibular teeth, and we can draw one arch. The moment we draw the arch, we get one panoramic-like image. Now, thickness of this image can be increased or decreased. So, I think this video is not working here. Okay, fine. That video is not working. The moment we draw the arch, we get panoramic image. Now this thickness of this panoramic section can be increase or decrease as per our requirement. Now here it has been kept around 20 millimeters, something like focal trough of panoramic radiograph. But now this image, if you observe carefully, there is no overlapping structures. Okay, and look at this vertical line passing through this premolar. We have one cross section created. These are called buccolingual cross sections, and one 3D image. I think again there is some problem with the. Okay. So when we talk about this, whenever you see any CBCT report, you will see these two reference images. One is panoramic and one axial. Can you see multiple numbers and lines here? Each vertical line corresponds with particular section. For example, look at this yellow line. This is number 10. It is passing through root of this mesially tilted mandibular right third molar. And we can see these two roots of this third molar on this cross section. This is buccolingual cross section. So now this B stands for buccal, L is for lingual, H is head, that is superior portion of the image, whereas F is foot, lower part of the image. So from these numbers, we can localize this cross section number and you will be able to do diagnosis. Now coming to anatomic landmarks which are seen on CBCT. So this is small FOV. Now if I say FOV, that is field of view. In CBCT we can take full skull view, maybe for single jaw or maybe for maybe set of 2 or 3 teeth, depending on size of FOV, field of view. Now this is small FOV scan showing maxillary molars. Axial, coronal and sagittal section. Look at the axial section, we can clearly see 3 roots of maxillary molars with, in center there are some black dots, those are root canals. Now this axial section is very much informative for studying root canal anatomy. Then we have coronal section and sagittal section. If you look at the sagittal section, lamina dura can be traced around the root very clearly. Now again, axial section passing through maxillary molar region, we can see 2 root canals in mesiobuccal root of maxillary first molar. And this is cross-sectional image passing through mesial root of mandibular molar. Now if you look at the two-dimensional image for mandibular second molar, look at the dialaceration here, it is getting curved mesially in apical third, distal root of molar. But when we saw cross-sectional image, it is getting curved on buccal aspect too. It is getting curved buccally. Whatever radiolucent area here, round radiolucency what you are seeing is actually mandibular canal. These are cross-sectional images passing through midline of maxilla, showing incisive canals very clearly. Now this is axial section showing incisive canal. Look at the shape of canal, how it appears on cross sections and how it appears on axial section. Now literature describe multiple shapes of incisive canal. This is midline, cross section passing through this midline. We can see incisive canal and on 3D image. Next, these landmarks we already saw. This is axial image showing nasal cavity and maxillary sinus. Look at the shape of sinus on axial image and on coronal section, and ethmoid sinus is above nasal fossa. On sagittal image, we can see sphenoid sinus with sella turcica and frontal sinus. Again, zygomatic arches, sphenoid sinus on axial and sagittal section. On coronal image, we can see infraorbital foramen and nasal septum. Again, zygoma on coronal section, we can see hard palate, above hard palate, nasal fossa and incisive canal. Now coming to osteomeatal complex. Basically this osteomeatal complex act as draining site for maxillary sinuses, frontal sinus and anterior and middle ethmoid sinuses. All drain in which nasal meatus? Middle nasal meatus. So this EB stands for ethmoid bulla. Then we have inferior and middle nasal turbinate. Turbinate is basically cartilage with mucosa above it. Okay. This red arrow is ostium of maxillary sinus. This star is shown is uncinate process. So, and this white dotted line is hiatus semilunaris. Now these three structures form a osteomeatal complex. Now importance of osteomeatal complex for dental surgeon comes when we plan for sinus lifting and grafting procedures. We need to look at this osteomeatal complex. It should be very much clear. So this patency of this ostium should be proper. If patency is present, then that indicates there is no sinus pathology. Now coming to some of the sinus pathologies, we have here, can you appreciate roots of maxillary molar showing some periapical lesion, and because of that we have odontogenic mucositis, mucosal thickening in the floor of maxillary sinus. There can be fluid accumulation or complete opacification of sinus leading to sinusitis. There can be dome-shaped grayish radiopacities, soft tissue opacities. This is nothing but mucus retention pseudocyst. Identification of maxillary sinus septum, because most of these septa are present near floor of maxillary sinus. Now for example, in this case, if you want to plan for sinus lift and grafting procedure, this presence of this septa can tear your sinus membrane which you are planning to lift. So identification of site of this septum is important. Assessment for lateral wall of maxillary sinus. Now this is maxillary sinus with its lateral wall and this medial wall which is forming nasal fossa. So this lateral wall contains some neurovasculature, that is posterior superior alveolar canal. Location of this canal is important again for creating lateral window in the sinus for sinus grafting procedures. Canalis sinuses. There can be accessory canal of canalis sinuses that exits on palatal aspect of maxillary anterior teeth. Now in this case, look at the section number 41. Now it is passing through maxillary central incisor. So this section number 41, this tooth is maxillary central incisor, and just palatal to this, can you see some radiolucent area line? This is accessory canal of, just I'm zooming it. This is accessory canal of canalis sinuses. Now with our two-dimensional or routine conventional radiography, diagnosis of these canalis sinuses was not possible. Now this is possible with this CBCT images. So this vertical hypodense line is noted extending from palatal aspect of this canine region, vertically going upward, laterally along the floor of nasal fossa. So this is canalis sinuses. Now on axial section we can see pterygoid plate, lateral and medial pterygoid plate. On sagittal section we have maxillary tuberosity and pterygoid plate just behind that. This anatomy is important for planning pterygoid implants. Now coming to mandibular landmarks, we have lingual foramen in midline on lingual aspect. So on buccolingual cross section, it appears something like this. This is sagittal section. There can be multiple openings of this lingual foramen. Now coming to mandibular canal, all of us know it starts somewhere from mental foramen. Now this is buccal cortex, buccolingual cross section passing through premolar region. Mental foramen exit. Then we have mandibular canal till lingual foramen, which is present on medial aspect of ramus. On cross-sectional image, this canal appears as circular radiolucent area. Now we have condyle and coronide process on axial section, mandibular condyle, we already saw this, then glenoid fossa with condyle on sagittal section. There can be multiple opening of mental foramen. This is just slight variation in anatomy. Now mandibular canal sometimes take an anterior loop, one U-turn, and then exit as mental foramen on buccal cortex. So, and sometimes it gives rise to mandibular incisu canal. The way we had incisu canal in maxillary arch, this is variation in anatomy, mandibular incisu canal. If it is very clearly defined, then it is significant. It may contain neurovasculature. Proximity of third molars to mandibular canal. Look at the note interradicular location of this mandibular canal in close proximity to root surfaces on 3D, and on buccolingual cross section. Can you appreciate this radiolucent area? It is mandibular canal passing between two roots of mandibular third molar. There can be retromolar or bifid mandibular canal or retromolar branches. So this is one of the branch. In third molar region, it can give rise to retromolar branches. Now location of this retromolar canal may complicate third molar surgeries. Then we have submandibular salivary gland fossa, which there is depression on lingual cortex in mandibular second molar region. So this is lingual cortex, this is buccal cortex, there is some depression. Now if I want to plan implant, if I go vertically, I have very less vertical height. If I tilt buccally, then I may have more vertical height. Depending on prosthetic requirement, I will plan my implant or give tilt. So this is virtual planning of implant which is actually perforating lingual cortex, and the moment you perforate lingual cortex during osteotomy, high chances of sublingual hematoma formation, one of the dangerous complication during osteotomy procedure. Now, this was one OPG taken. There was some incidental finding of some radiolucent cyst here. So this was diagnosed as Stephane's cyst, that is accentuated submandibular salivary gland depression. Now, fortunately, this patient went for CBCT for implant planning in these areas, and we could see this cyst. Actually, it is pseudocyst. There is depression on lingual aspect, and which may contain some submandibular salivary gland structures. Now, coming to some of the common clinical application of CBCT. Most common application is planning implants. We can assess the alveolar bone height and width of buccolingual width of alveolar bone available in mandibular anterior region. This is buccolingual width, and height can be extended till lower border of mandible. In maxillary anterior alveolus, we can take height till floor of nasal fossa. In maxillary posterior region, nearest landmark is floor of maxillary sinus, and in mandibular posterior region, we have mandibular canal as important anatomic landmark to measure height of alveolar bone with width, buccolingual width at the alveolar crest. We already saw importance of this lingual undercut, very much common in mandibular second molar region. Bone density can be measured on CBCT. It is slightly subjective. This is most dense bone, whereas this is D2, D3 and D4 kind of bone. This classification we generally follow is Latham and Zub, depending on thickness of cortical bone and density of cancellous bone. So this density analysis is slightly subjective on CBCT. When we compare this on CT scan, we get exact Hounsfield units. Now when we plan for implant, we need to know minimum recommended distances from adjacent implant to tooth distance, implant to vital structures, between two implants, and buccal and lingual cortex. So we can, on this 3D imaging softwares, we can virtually place the implant and study in detail about bone which is present around the implant. So this software allows nerve mapping, virtual implant placement and measurement tool to digitally assess the implant site with virtual rendering bone. Now, to study hidden canal anatomy, this is mandibular first molar presented with kind of irreversible pulpitis, symptomatic periodontitis. This is preoperative IOPA showing two roots with root canal. So on CBCT, here we can appreciate three mesial canal which are observed on axial slice of CT scan, which is verified clinically, and all these three canals are addressed and post-op IOPA radiograph showing these three canals. Now this is mandibular mandibular lateral incisor showing two root canals. Now this is a case of periapical pathology. If we look at 2D image, we feel root canal is perfect. Three canals are completely filled. But when we saw CBCT, there was periapical lesion. Sinus was completely opaque, indicating sinusitis, and MB2 canal was not addressed. So after post-treatment, MB2 canal was addressed, and we can see this MB1 and MB2 canal which are filled. Root fractures, this is maxillary second premolar. Now if we look at 2D image, we can see single root with some fracture here, but actually it is fracture of palatal root of maxillary second premolar. Another case of root fracture, crown and root fracture. These axial slices will show exact extent of these fracture line, and this is one cross section showing the fracture line. So these axial sections are very much important for endodontic evaluation and study of these root fractures. Now this was a case of radicular cyst. This is 2D image. We take sagittal slice, we can see the cyst with its cortical border very clearly. Another case of radicular cyst involving 2-1 and 2-2, maxillary left, central and lateral incisor. On this cross-sectional image, this is B, buccal and lingual or palatal area. So we can see thinning and expansion of labial and palatal cortices very clearly. So when we saw axial section of same case, look at the incisive canal, it was already involved by this radicular cyst. It helps in planning our periapical surgeries. Dialaceration of roots, which is clearly seen on CBCT sagittal section. Impacted tooth, assessment of impacted tooth. Look at the interradicular location of this mandibular canal between buccal and lingual root of impacted third molar. Assessment of impacted canines. Exact location of canine helps in planning maybe disimpaction procedure or surgical exposure for orthodontic treatment purposes. Then one of the pathology here, there is pericoronal radiolucency involving impacted third molar. Maybe third years, I want to wake you up. There is pericoronal radiolucency around impacted third molar. Can you give a differential diagnosis? Great. So everyone is awake. Thank you. So we can see extent of this pericoronal radiolucency. There is root resorption of mandibular second molar. Mandibular canal is pushed downward near lower border of mandible. Look at the mandibular canal. Superior cortical margin of this canal is lost. So you can confirm this clinically by asking patient if there are any symptoms of paresthesia. Okay, this is another pathology. This is odontogenic pathology occupying space of maxillary sinus. There is well-defined homogeneous hypodense expansile lesion noted within right maxilla. It is starting from periapical area of this 1/6. And look at the margin walls of the sinus and cortical margin of that pathology. So it is odontogenic pathology occupying space of maxillary sinus. It is very clearly seen on these axial and coronal sections, and this is sagittal section. There can be some calcification which can be detected on CBCT. This is silolith present on lingual aspect within the floor of oral cavity in soft tissue. Assessment of TMJ, temporomandibular joint. What do you see here? Look at the cortical margin of this condyle. This is lateral pole, medial pole, and superior cortical margin, there is erosion. So this is coronal section, this is sagittal section, showing location of this condyle. If we take CBCT with open mouth position, we'll be able to see this condyle moving forward against the slope of articular eminence. So basically there is erosion. These are degenerative changes, degenerative joint disease. So we can confirm clinically with correlation with patient symptomatology. Now as a concluding remark, this radiology, when we advise radiograph, we should weigh the risk versus benefit. What are the risks in radiology or this advising radiograph? Radiation exposure for patient, right? And what are the benefits? Patients, treating doctor get some diagnostic information that can be utilized for patient's treatment. So that is benefit. So whenever possible, go for minimum possible radiation dose or minimum possible radiograph to be advised. Look at with CBCT, look at the radiation exposure, it is almost 68 microsievert. When we compare this with one OPG, it is 15, almost equivalent to 4 OPGs. Okay, now this is CBCT for both the jaws. If we go for small volume scan, obviously it is going to be very lesser than 1 OPG. So judicious selection of these radiographic views or radiography or imaging, possible imaging is important here. Thank you.
Thank you, Rohit. This was very awakening call actually, because it's a black and white picture, made us clear view now. Okay, thank you very much. Any questions? Thank you very much.
Thank you, sir.
So our next speaker is regarding the barriers obtaining in biopsy. It is my pleasure to welcome you all to today's next session, where we will be discussing an important and often overlooked or a conflict aspect of a clinical practice in oral pathology, the barriers in obtaining a biopsy. As a student and a future dental professional, you are taught that biopsy is the gold standard for diagnosing many oral lesions. It provides definitive histopathological evidence that guides treatment decisions and ensure patient safety. But in real-world practice, performing or referring a case for biopsy is not always straightforward. There are several barriers in taking good biopsy, and understanding these challenges is crucial for developing responsible and proactive clinical habits. So, why this topic is important for you as a student? Because you are the future clinicians and the gatekeepers of early detections, learning how to recognize the need of biopsy, how to do a good biopsy, and need for healthy communication between surgeons and a pathologist to overcome your own hesitations. So today's sessions will explore not just the technical side of biopsy, but also reveal the world factors that influence decision-making in clinical setting through evidence-based search. Together, we'll discuss strategies to overcome these challenges and build a more confident patient-centered approach to the oral surgery and oral pathology. I welcome Dr. Niharika Swain, Associate Professor, Department of Oral Pathology, MGM Dental College and Hospital, a PGU alumnus of Dr. R. Ahmed Dental College, recently completed her PhD in Medical Genetics, won award like a Best Oral Pathologist in the Year, scholarship awarded by Next Generation, that is Genomics, Biology and Informatics and Technologies, for her highly qualified research in the international platform. Many Best Paper Presentation Awards in national and international conferences. She has active participation in government-funded research project, along with the many more national and international publications, books and book chapters to her credit. And many more are there. I welcome Dr. Niharika to share her knowledge.
Thank you, sir, for this elaborative introduction for me and my topic. Since morning, we are going through lot of lecture where we have gone through the clinical history, examination process, radiographic images right now by Dr. Rohit. Welcome to one of the most conflict zone, which is in between in medicine field, which is still going on. Going back to the history, some wars have been completed like World War I and II, and few age-old fights are still continuing. That we all know, outside our country, with our neighboring country, and in lighter note, in our homes also. In the field of medicines, this is a most famous war zone or conflict zone, you can say, between surgeons and pathologists. And the matter is insufficient tissue. They said always we have given sufficient tissue and our defense is insufficient tissue for diagnosis. So it is not only restricted to oral or oral surgeon versus oral pathologist. If you see in the field of gynecology, I am given a few evidences where else we are seeing this conflict. So in the field of gynecology, you are seeing that the report is saying the 4 out of 5 reported patients with insufficient or scant tissue. In gastroenterologist also, enterology field also, there is complaint of superficial sampling is the major concern for the gastric biopsies. When you are talking about so much of molecular biology, we are hunting for the biomarkers. There also, when the research has been conducted to understand that whether these biopsies are sufficient or not, they have concluded core biopsy was more prone for insufficient tissue sampling than FNACs. So we have differences. We have to agree that. Honest differences are often a healthy sign of progress. That is the quote of Gandhiji. With that, here I am presenting today's talk, barriers in obtaining biopsy. I rather say good biopsy for histopathology. And I am Dr. Niharika Swain. So what are the facts for this controversial diagnosis in oral biopsy? So I'm not going to tell my opinion. It is all about the evidences what we got right now. I will personally thank this group of surgeons who have actually conducted a research which is very, very important, and they found out that the factors which are reasons behind this controversial diagnosis in oral biopsies, the major reason up to 60% were sampling error. Second comes pathologist discrepancies, we admit that. Insufficient tissue biopsy, inflammation obscure diagnosis are the major 4 reasons for these conflicting diagnoses. They have not stopped over there, or they go back to 2007. This similar group of researchers done this research on oral leukoplakia in National Taiwan University Hospital to find out that factors associated with underdiagnosis from incisional biopsy on oral leukoplakia patients. So what they have found out is again more shocking. Underdiagnosis rate is more in single biopsy site, that is 30% more than that the multiple biopsies. Non-homogeneous oral leukoplakia, what we always thought to be having the more malignant transformation rate, showed a higher rate of underdiagnosis biopsy specimens, shocking again. So what they have suggested, the surgeons have suggested sufficient and representative biopsy samples are important for the histopathology, and understanding this is very, very important, understanding the confounding factors can improve the technique modifications which we require the most now and increase the overall accuracy. So I'm putting forward some general guidelines, not by me, but given by the literature for a good biopsy. Okay. So you might be knowing that we should not inject LA on the target lesion. That I think everybody will going to agree. So if you are going to see this, if you are choosing a excisional biopsy like here, you choose 4 point or the 4 cardinal reference point to inject this, not directly on the biopsy site, but 3 to 4 millimeter away from that. That is going to give that privilege of diagnosing by us without seeing this tissue separation. Otherwise, we're going to give the tissue separation, which is going to give another nightmare to us. Please use sharp surgical scalpel. If you are going to do this use of, or you're going to use the tissue forceps, electrosurgery and lasers, then we have all these defects or artifacts which are going to all contribute to a it's not going to contribute in a good diagnosis or good histopathology. Avoid the areas of necrosis if you are going to operate on right on inside this, then or in the area of ulcerations. So this is not going to give any kind of view of epithelium, targeted epithelium or connective tissue, what you want to see and diagnose upon. Surgeon here may think in the third diagram, upper third diagram. So if you can see that they have given enough tissue, but what they have given, they are blood clots. What you are going to see is only the area of hemorrhage and the fibrin clots. That is also not going to give the proper diagnosis. If you are seeing an area of inflammation, don't jump into that. Go to the boundaries, take this, otherwise you will land up in the inflammatory zone where also we cannot decide upon what is the interactions between the epithelium connective tissue or details of the epithelial connective tissue over there. So why I am behind this inflammation? As oral pathologist or pathologist, we all know that can induce pseudoepitheliomatous hyperplasia. In this particular histology or histopathology, you can see the whole of the lesion is filled with this pseudoepitheliomatous hyperplasia, which is not going to give any kind of definitive diagnosis what you want for. So that's we have to, we are always telling that avoid the area of inflammation. So why to reduce the inflammation before go for biopsy? Another reason is if you are going to in the inflammatory zone or the choosing the area of inflammation, this inflammation can cause reactive atypia. Reactive atypia is a very much reversible conditions. When the inflammation is going to withdraw or you are going to abolish this inflammation, that could be a normal epithelium. So to differentiate between the true dysplasia and reactive atypia, we have to avoid the area of inflammation or reduce the inflammation before biopsy. If there is a small lesion on any kind of surface, if your tongue or any buccal mucosa, if you see the small lesion, but you are suspecting oral malignancy, or oral cancer, don't jump into the excisional biopsy. The study shows, again the surgeon have done this study, excisional biopsy was associated with less available pathologic data, that is the margin status, whether the margin is clear or not, how much the tumor depth was, which is going to actually affect the adjuvant therapy. Further radiotherapy and chemotherapies are going to be affected. So resist the temptation. Don't go for the excisional biopsy. Always these questions arise, what size, does the size matter? I have given enough tissue, you have to give the report. Does size matter? Yes, size matters. This is exactly this group of, again surgeons have done the biopsy of oral mucosa. Does size matter? So what they have given, we are always thinking of that 7 millimeter, 5 to 7 millimeters is quite enough. We can diagnose, but we always land up in that insufficient tissue. They have exactly found out that the same problem, diagnosis may be compromised, that their language, I have not edited it also, when decreasing the biopsy specimen size, in order to maximize its diagnostic outcome, 10 millimeter long sample may be recommended. So I'm not talking about the length right now, but what I have they told that beside this, basement membrane and underlying connective tissue are also mandatory, and depth is very critical. So you have seen, everybody I think seen this very old photograph and favorite of me. So we can see that it has been big sample. According to that, it's a very good amount of sample, but broad and shallow, not going deep into the depth of your lesion. Rather than this, which is narrow, but going entire depth of the tumor and touching the normal tissue, which is in the basement membrane and connective tissue. So this is going to work for us, not this. Yes, size matters because tissue also shrinks. In head and neck cancer studies, they have said after the formalin fixation, the tumor margins shrank from 47, about 50% to 27%. This was all talking of the margins which are very crucial for the adjuvant therapy. Now, what about the core biopsies? So what this surgeon has already done my job, that is shrinkage of head and neck cancer specimen after formalin fixation. They have reported that average decrease in length, all three-dimensional length, width and depth, and that contribute to 15% of the shrinkage. So these are some few guidelines or few evidence I have shown that why there is a need of thinking of in a good biopsy and good depth or good size. So here lesion specifically, I'm going to show some of the lesion, how to manage to get a good biopsy. Leukoplakia. This is a whole know everybody, we go for biopsy of leukoplakia here and there. So this is a guideline presented by Tata Memorial Hospital. So when to do a biopsy in leukoplakia? If you are seeing an ulcer and erosion that is persisting for 3 weeks, more than 3 weeks, lesion 200 meters square, that we know all risk factors are there, non-homogeneous in nature, 3 years, if you know what is non-homogeneous oral leukoplakia, tongue and the oral floor of mouth, 40 years of age if you are above than that, female gender without any known risk habit, palpable cervical lymph nodes, history of cancer, spectral leukoplakia suggesting of your candida infection or any leukoplakia which is over 2 years of duration. How to choose a biopsy site? It has to be from most suspicious area of the lesion, that is redness, or it could be a surface thickening, or it could be any symptomatic area you are also thinking of. It could be a hazardous area, then you take the biopsy from that. If it is multifocal or widespread leukoplakia, multiple biopsy is recommended. Small leukoplakia, then you have to excise it if it is less than 2 centimeter. Oral submucous fibrosis, we normally don't recommend a biopsy for its diagnosis because it's based on purely clinical diagnosis. But if you are seeing OSMF with any other OPMD, whichever stage it is, whether 1, 2, 3, 4, whatever you stage tell, but if it is been associated with any kind of other OPMDs or presence of growth, any kind of growth if you are suspecting, present of any ulceration more than 3 weeks, but it is not going away after the etiology removal, then urgently do a biopsy. Next, the much more conflicting zone, the core of the conflicts between the oral surgeons and oral pathologists is oral verrucous lesion. It has having a series of your lesions which can be benign counterparts and malignant ones also, and most controversial is verrucous carcinoma. And after 2014, this et al. Has given, this surgeon, they have given a very, what can say, I say offensive, because they have said reliability of incisional biopsy is, it is not reliable at all if you are going for a oral or you are diagnosing a oral verrucous carcinoma. Okay. because of the experience of 55 patients they have chosen, which was diagnosed by them, that was 53 verrucous carcinoma and 2 verrucous hyperplasia they have taken. After excision, they have found that 27 were again verrucous carcinoma, but 28 were hybrid BC or hybrid verrucous carcinoma. What is hybrid verrucous carcinoma? That is verrucous carcinoma with foci of squamous cell carcinoma. So they didn't find anything is going to be verrucous hyperplasia, everything either VC or verrucous carcinoma or verrucous carcinoma with squamous cell carcinoma, which is shocking for them. That's why they have labeled the incisional biopsy as should not carry out. So I was been in conference very recently where the surgeons were telling that there was a debate whether we should go for incisional biopsy for oral verrucous carcinoma or not. But we should look into the other matters. The other areas of verrucous carcinoma reports, we are seeing that they are asking for help with the wider or deeper skin biopsy or sole biopsy or ear biopsy. They have all reported there is a need of your biopsy, the incisional biopsy is there. So now where to go? Yes, surgeons should be scared of this because if you see there is reports the coexistence of your verrucous carcinoma and squamous cell carcinoma occurs in 20% of verrucous carcinomas. Yes, according to those reports, what was controversial, who was saying that the incisional biopsy is not sufficient. Yes, 51% cases of your oral verrucous carcinoma or benign precursors are actual hybrid lesions. So before on your clinical presentation, if you are seeing a verrucous carcinoma, this means 50% cases they are maybe associated with the foci of squamous cell carcinoma. So why to go away from incisional biopsy? Why not to do an incisional biopsy and good incisional biopsy and see that whether carcinoma is there or not? So to call the incisional biopsy is insufficient. I think that they have to change their approach to that. How to get a good incisional biopsy is a requirement because hybrid BC is very, very dangerous. It has to manage like squamous cell carcinoma. Now to understand our view, this is what we want. A bit of your normal epithelium and then pushing border and all the features of verrucous carcinoma. This is an ideal situation where you can always tell that this is BC. But what we get? Insufficient depth, only the part of epithelium, proliferating epithelium, no connective tissue, then you cannot judge anything. Cross sections, because the lesion is proliferating, many of the time we are seeing cross sections, difficult to analyze. And then inflammation again. Okay, so zone where we have to see the epithelium is going for any kind of early invasion, there also the problem. So they have to listen to us also what we are suffering from. This is not the one way always. Now, cherry on the top of the cake, you can say that is another lesion coming out, the verrucous hyperplasia, which is just behind that. People are calling that benign precursor of verrucous hyperplasia over here, just behind it. They have also exophytic pattern, they have also endophytic growth pattern. Okay, so when you are doing for any kind of biopsy, if you are choosing a biopsy depth for this lesion, can we have the similar depth to the where you have exophytic, endophytic? Is it wise enough? I think you have to increase your size of the depth or increase the depth. So one size doesn't fit for all. And you can see that the overall 5-year malignant transformation rate was up to 10% in this verrucous hyperplasia, which is considered to be a very much benign lesion. Now we have seen through, and I thank one of the surgeon who was wise enough to give the entire depth of this lesion, and we have seen, if you see up to this is looking like so good verrucous hyperplasia, but beneath this you can see the areas of squamous cell carcinoma. So there is a new entity can come, the verrucous hyperplasia with foci of SCC, and you can call it hybrid verrucous hyperplasia. So we have endless nightmares. That's why I am talking about Dept is very much mandate over here. This is not like you have to just pick one grain of rice to know the status of the whole pot rice. No. We have to choose because we are dealing with the field of carcinogenesis. We don't know clinically where the lesions are going and going down so much. So in that case, it is not the one area which can tell you the entire story of this oral carcinogenesis. We have to pick up many bits, and yes, we are at the iceberg's tip. We have to go deeper and just judge the depth. Okay, so that's why multiple biopsies with adequate depth from different areas of the tumor might be helpful for identify the invasive component. That's why it's very humble request to all the surgeons who are online or offline, please go deep. Then comes another similar type of conflict zone, that is mucocutaneous lesions. Every time we are saying that the epithelium is not there, you are saying that only inflammation is seen, then we are not going to give that definitive diagnosis. Why these complaints are coming up? If you are talking about any kind of active erosive or pseudomembrane, white grayish membrane is there, or intense inflammation, don't take biopsy on that particular zone. It's not only just disturb the tissue integrity, but also we are always seeking help in the form of your immunofluorescence. In case of immunofluorescence, you need immunoglobulin and complements to be there, but if you are going to that particular areas, then it is going to destroy them. So in DIF also, we are not going to get the result. So what was the expectation? We'll want that part of your epithelium, connect tissue, but what we are getting? It's all bald. And here it's going for an epithelium and connective tissue in oral lichen planus also we are getting, but what we are getting is just bit of your epithelium, nothing showing down. So this fits good. This is how we expect, and this is how in real life what you are getting. So there are some advices. Sample must be taken from healthy areas as close to, this is a general guideline, from the very close to the active lesion. If you have no space, there are no space available, so rest you can target a tissue from 2 to 3 millimeter from any erosion edge within 1 centimeter of radius. If you have enough tissue, then go a little much farther away and from an area of apparently healthy mucosa, take a biopsy. If mucous membrane pemphigoid and PV is actually on the gingiva, then target gingiva. If whole gingiva is involved, then go for alveolar mucosa. Or if you see multiple oral lesions are there, then go for any healthy mucosa, you will get the result. It increases the capturing the immunoreactant, what we are required for your DIFs, or it can also preserve the tissue quality. So another very important piece of advice is you can see that if you have a bulla, then don't target the bulla because it's very tempting to target the bulla. You will get something which is very histopathologically going to be enough. No, it is going to rupture as soon as you want to take the biopsy, and again you have an ulceration without epithelium. We require epithelium. So it has to be always the adjacent to bulla, perilesional. It is better to take broader, this is very much important, broader, shallower and longer biopsy in case of this. Deep depth is not required. I repeat, depth is not required here because we are talking about the interaction between the epithelium and connective tissue, which is surface phenomena. Gingival biopsies should be avoided because it is already been close to the all the calculus plaque or everything that can give you the chronic inflammation as such. So avoid gingival biopsy as it is. It should not be confused with that the inflammation, chronic inflammation part of the disease. If you patient with your topical steroids, then discontinue it before taking the biopsy at least 1 month ago. So you cannot go for the if patient is under corticosteroid, and you can go for this. So it is going to hamper the histopathologic and DI finding. Oral lichen planus, we always, that there is a WHO criteria, you have to take a biopsy to give the proper diagnosis of oral lichen planus, it's mandatory. Biopsy from the non-erosive area, avoid that erosive areas. If the gingival erosive lichen planus we are dealing with, then DIF is going to contribute, not your histopathology. Intral, if you are taking DIF, what are the suitable areas? Upper labial mucosa, hard palate, and cheek mucosa. This is another lesion where we are always in a fight. They ask us, why not you give us the diagnosis of whether it is unicystic ameloblastoma or not on incisional biopsy. This is a picture which is going to tell you why it is not possible. We have luminal, intraluminal, and mural that cannot be placed in one area, that can be distributed throughout the lesion. If you are going to give this area as an incisional biopsy, I may not give you that it is the entire picture of what is the mural involvement is there or not, because treatment plan is going to vary in luminal, intraluminal, where you have to do your enucleation, or you can have a conservative approach. When you see mural, then you have to go for, as per the conventional ameloblastoma, you have to treat like that. So you cannot ask for a definitive diagnosis on the basis of incisional biopsy. It is recommended always give the whole specimen, then we can give the diagnosis of whether it is a unicystic ameloblastoma or a conventional ameloblastoma with cystic degeneration. Now this is the last but not the least lesion, but it is one of the most aggressive ones where you have to always take precautions to having then good diagnosis. So in a large multicystic ameloblastoma, what you go for, that if small biopsies are taken from the most accessible area, from the posterior mandible, you are dealing on a part of that particular cystic lesion which looks like, or histopathologically may look like, a developmental cyst. But what we are reserving is the ameloblastoma with a large cystic area, and we are going to give that particular incisional biopsy and get that particular diagnosis, which is going to be away from the true diagnosis of ameloblastoma. So this is a request for oral pathologists that it is been reasonable in this situation. You request further for a larger biopsy, don't hesitate. Don't hesitate to tell to your oral surgeon that this is not sufficient, we want more. So enough fighting. I think it's when we start working together that the real healing takes place. So it's time to collaborate, time for a discussion among the case-to-case based discussion among the oral surgeons and oral pathologists to understand each other's problem and take the patient's diagnosis and patient care to further. This is my wings and my strength. So I thank my department, all my teachers, my fellows, my juniors, and my PG students, sweet PG students who helped me for so long to travel. Thank you very much for giving this opportunity to talk.
Thank you, ma'am, for the wonderful presentation.
हे लाव ना नाही हे जाय रेकॉर्डिंगसाठी लावायसाठी ओरिजिनल फक्त हे आतून करा.
The next session is focused on a rapidly advancing and essential branch of diagnostic science, that is molecular pathology, and its growing relevance in the field of oral pathology. As students of oral pathology, you are already familiar with histological patterns, tissue changes, and microscopic features of the disease. But beyond the tissue, beyond what we can see under the microscope, lies an even deeper layer of information. the molecular and genetic mechanisms that drive health and disease. This is where the molecular pathology comes in, the study of disease at the DNA, RNA, and the protein level. It is helping us to answer the whys and hows of the disease progression, transformation, and response to therapy. While the subject may seem complex at first, today's session is designed to introduce you to the basics in a student-friendly way, covering fundamental techniques like PCR, immunohistochemistry, and next-generation sequencing, and how they can be applied to real clinical cases that you may encounter. We hope that this session will ignite your curiosity, broaden your understanding, and help you see how oral pathology is evolving beyond the microscope into the molecular era. The speaker of this session is Dr. Shraddha Gaisas. She is working as an assistant professor at MGMDCH College and Hospital. After her MDS, she has completed her postgraduate diploma in omics technologies from IIT Jodhpur, and she is currently pursuing PhD in cancer biology from Symbiosis International University, Pune. So let's embrace this exciting field with open minds and a readiness to learn. So here I welcome Dr. Shraddha Gaisas to share her knowledge with us.
सगळं ओपन आहे
नाही हे मॅडम तुमचं करा
नाही मला ना वेगळं कॅनवा मॅडमच्या ह्याच्यात नाही आहे मला कॅनवाच ओपन करू
विषय बरं आहे सकाळ बघितलं
हो हे बरं आहे हे मॅमचं आहे लॉग आउट कंटिन्यू अनदर ईमेल
व्हिडिओ नाही ना कुठे व्हिडिओ
आहे व्हिडिओ आहे
Good afternoon, everyone. So since morning we have been building the basic foundation of diagnostic pathology strongly. Now we will move little bit towards advance. So I'll be talking today on molecular pathology redefined from immunohistochemistry to next generation sequences. So basically, what is molecular biology? It is a branch of biology that deals with biological activities. It studies molecules like RNA, DNA, proteins, which helps in understanding gene expression, regulation, and mutations. I'll just enumerate the techniques involved in molecular biology. It is not possible due to time constraint to cover each and every technique in depth. So I'll just enumerate. Coming to nucleic acid techniques, initial step is DNA RNA extraction, which involves isolation of nucleic acids from cells and tissues. The second is agarose gel electrophoresis, which separates DNA and RNA based on size. Then is spectrophotometry, which quantifies the DNA. After isolation, you check whether the amount you have received is sufficient or not. You check the quantity of the DNA, that is done through spectrophotometry. Then is common technique, quantitative PCR or real-time PCR, which studies the gene expression. Then is reverse transcriptase PCR. So in case of reverse transcriptase PCR, we study RNA. RNA is not stable because it is single stranded. So it is not stable like DNA. So we convert RNA to complementary DNA for amplification. Then we have protein techniques. So there is protein extraction and purification. We isolate proteins from biological samples. The most common is Western blotting, where we study only specific proteins. ELISA for quantification. Mass spectrometry, where you can study 10,000 proteins together. Sequencing and genomics is a whole new theme now. So we have whole genome sequencing, we have RNA sequencing, we have ChIP-seq, we have methylation analysis for studying the epigenetic modifications. So I'll start with immunohistochemistry, which is a bread and butter for us. In 1941, Albert Kunz developed a direct staining method using fluorescent labeled primary antibodies in frozen section. Fluorescent labeled, fluorescent means it was emitting the light. So that was first studied in 1941. Then early 1970s and 80s, enzyme labeled antibodies were found replacing fluorescent ones for routine histopathology. And 1990s saw complete automation and monoclonal antibodies came into picture. So I'll explain the procedure of IHC. So you can imagine over here, this blue cell is the normal cell. Red color is the antigen. The antigen is any sort of protein. It can be present within the nucleus, within the cytoplasm, or over the cell membrane. In the pink color is the primary antibody. The first to bind is the primary antibody. After primary antibody, we incubate the antigen with primary antibody for around 30 minutes. Then we add secondary antibody. So secondary antibody always bind with the primary antibody. In the next slide, you can see Dept chromogen is there. So basically, the main picture is played by Dept chromogen, which gives brown color staining to the cell. So over here, you can see if Dept chromogen is present, if it stains brown, that means my antigen is present. That means the target is present and it is positive. When the Dept chromogen is absent, the target is absent and the marker is absent, antigen is absent. So this is the basic of immunohistochemistry. Now I'll start with steps of IHC. So fixation is very much important because it preserves the tissue morphology. Routine neutral buffered formalin is used. The next step is antigen retrieval, where we unmask the antigen. So epitope is the site for epitope is the antigen binding site. So we use heat induced or enzymatic retrieval method. Then to avoid non-specific background staining, we block it using peroxidase or protein blocking, and then we label it with the primary and secondary antibody. We incubate with both the antibodies. So again, it depends on the type of marker and the instructions of the manufacturer. So recommended instructions are to be followed, which are different for each and every marker. So type of staining, after staining, the staining can be nuclear, it can be membranous, or it can be cytoplasmic. Next technique is polymerase chain reaction. So key developments in PCR in 1983, Carey Mullis invented PCR while working at CETUS operation. 1985, the term PCR was coined, and 1990 saw development of reverse real-time PCR for quantification of DNA. So you can see 1940 ISC started, 1990 there was RT-PCR. So what are the basic components present in PCR? It consists of template DNA, primers, DNTP, stack polymerase and buffer. Template is the target DNA. Over here you can see this is the target DNA. So in some cases, like in microorganisms, the amount of DNA is very minuscule. So you need to amplify that. That's why that will be your target DNA. So PCR helps in amplification of DNA. Then we need primers. Primers are the short sequences of DNA. They are short sequences of oligonucleotides. When I use this term oligonucleotide, I mean thymine, cytosine, adenine and guanine. So there are 25 bases which forms an oligonucleotide primer. So you can see over here, first denaturation takes place. Denaturation occurs at temperature of 94 to 95 degrees Celsius. The DNA melts and gets converted into single-stranded DNA. Over here you can see the two strands have separated. Then comes your annealing. In case of annealing, the temperature falls down again. It is from 50 to 62. Okay, and over here you can see the primer is binding. So this is the upper strand, this is the lower strand. Over here the primer is binding at the 3' end. Over here this side downward strand, the primer is again binding to the 3' end. So over here the annealing is being taking place in forward direction. Over here the annealing is taking place in reverse direction. And then there is elongation and you will see multiple copies of DNA. So the polymerase which is used is stack polymerase. This enzyme is quite heat stable. So in this you can see initially there was one copy of DNA. After first cycle there were 2 copies. After second you will see 4, and in the third you have many 4, again 8 copies, and like that we continue for 20 to 30 cycles normally. So now we use thermal cycle for DNA, where we can adjust the time and temperature of the machine. Initially they were using water baths. So there were 3 water baths, like how we melt paraffin. So similarly there were 3 water baths with different temperatures. So the technique is based on enzymatic replication of DNA. In PCR, a short segment of DNA is amplified using primer-mediated enzyme. DNA polymerase play main role. They synthesize new strand of DNA complementary to template DNA. The DNA polymerase can add nucleotide to the pre-existing 3-OH prime group. Therefore, primer is required and more nucleotides are added to 3' end of the DNA polymerase. So you can see the 2 strands are getting separated. The temperature is 95 degree. Then annealing, where the primers, which are the known sequences of DNA, get attached with the target DNA. So this happens at 55 to 65 degree. And you can see extension. This is the enzyme which is going on adding the nucleotides at 72 degree. So this PCR is being used in current Illumina MGS technology also. Now coming to types of PCR. So conventional PCR, which amplifies a specific DNA fragment. Real-time PCR. In case of real-time PCR, you see the amplification and it quantifies the DNA. In this you use fluorescent dyes or probes. Then reverse transcription, which was used during the COVID, because RNA, as I said before, it is very unstable. So we convert RNA into cDNA by reverse transcriptase, and then we can continue like conventional PCR. And multiplex PCR. In case of multiplex PCR, you have many targets. You have more than 2 primers. Okay, many primers, many targets. Now nested PCR has come, where there is forward and reverse construction. But then I will not go into depth of that. Now applications of PCR. So first is diagnosis of infectious diseases. Example related to oral pathology is detection of HPV in oral squamous cell carcinoma. You can identify pathogenic microorganisms. You can actually take tissues. You can study the types of oral candida which is present. There are 5-6 subtypes. Glabrata. Okay. So you can just study which is predominant in which case. Then there are research applications in OPMDs also. You can study multiple gene expression in oral leukoplakia and OSCs. These are examples for applications. Now I'll start with microarray. So microarray is considered as the father of next generation sequencing. In 1975, Edwin Southern developed a method to detect DNA fragments using radioactive probes. So don't get scared by these big words. Radioactive probes are nothing but again they are short segments of DNA. This was the first major step towards studying specific DNA sequences. In 1989, the concept of array was introduced. Scientists started placing many DNA probes on a solid surface to detect matching sequences. So in case of microarray, I'll just explain you shortly. Just imagine it is like a glass slide. The slide is little large. It is 1 by 3 inches in diameter. You have micro spots over the glass slide. There are 6 spots in the column, 6 spots in the row. I have the picture. I'll just show you. First you understand. So within the spots, you have single sequences of DNA. Okay, and you isolate DNA fragments from your tumor tissue. You can isolate from healthy tissue. Okay, after isolation of DNA, you can convert those into single-stranded DNA, and the single-stranded DNA gets hybridized with the already present DNA tags on the slides. So this was the concept behind microarray. So microarrays are collection of DNA probes. DNA fragments from sample gets attached with the probe. The probes are generally oligonucleotides. Labeled single-stranded DNA from a sample of interest is hybridized to the DNA microarray. The amount of hybridization is very important because you can detect that through the fluorescence, and it will quantify the nucleic acid which is present. So this is the picture. So you can see over here healthy cell is there, pathological cell is there. You are isolating the RNA from cell culture. Then you are converting it into complementary DNA. You will tag the complementary DNA with a fluorescent dye. And on the right, you can see if the fluorescent, if this DNA gets hybridized with the already existing oligonucleotide sequence, you will see different fluorescence and colors. So if it is green in color, that means your normal cell, normal genes are prominent, they are expressing. If it is red in color, that means the genes in cancer are highly expressing. And if it is yellow, that means those genes are present in both cancer and normal tissues. So working of microarray, when a gene is expressed in a cell, it generates messenger RNA. Overexpressed genes generate more messenger RNA than underexpressed genes. This can be detected on the microarray. The first step in using a microarray is to collect healthy and cancerous tissue samples from the patient. This way, doctors can look at what genes are turned on and off in the healthy cells compared to the cancer cells. So why do we need? Because biological systems are one of the most complex systems to mankind. We have thousands of genes and protein expressions changing in tandem in response to external and internal stimuli. For a biologist to be able to track all these changes simultaneously is not a small task. Conventional techniques, like in case of IHC and PCR, you have been studying just one target. There is need for techniques that can track thousands of genes or proteins simultaneously. Time efficient, high throughput techniques are the need of the hour, and microarray is one of them. So applications, you can simultaneously monitor the expression of thousands of genes in normal and diseased tissues. By analyzing gene expression profiles in precancerous lesions, microarray can help identify individuals at high risk of developing oral cancer. You can identify biomarkers which can act as a potential drug target. Also, you can identify genes associated with chemoresistance. So now I'll start with fundamentals of NGS. NGS is next generation sequencing. I have few questions for you all. Why do some people become seriously ill while others remain healthy throughout their lives? Why do drugs work optimally for some patients but not for others? This we have seen during COVID also. Some were responding to remdesivir, others were not. Why do certain plant species exhibit varying levels of resistance to pests and diseases? How do the individual factors contribute to a disease and how can they be influenced? What could be the answer for all these questions? So there is just one answer, that is genetic variation. So these are the example in oral. This is the example in oral pathology. You have two patients. Suppose patient A comes to your clinic. He has leukoplakia patch on the tongue. Patient B is also there. So that patient also comes. The site, location, everything is same. But you will see eventually patient B progresses to cancer. So what could be the reason? Patient A is quite normal. Both of them have almost same lesion, same everything. So in case of patient B, there are genetic variations that That's why the patient is progressing towards cancer. There could be polymorphism in TP53, glutathione, then cytochrome and cytochrome 450 and EGFR genes. So genetic variation plays a very important role in progression of cancer also. Now what is genetic variation? We all know our DNA is made up of 4 letters: adenine, cytosine, thymine, guanine. But there are many ways in which sequences of these bases can be altered. One letter can be changed into a different letter. A can be changed into G, C can be changed into T. The order of letters can be changed. One or more letters can be inserted or deleted. The effects of these changes are very variable and mostly unknown. But we do know that across the whole genome, each of us has millions of differences from the reference genome without any ill effects. Tomorrow I might have abnormal letters, but then I have 2 copies of DNA, one from my father, one from my mother. So my one copy might be correct, that's why I'm not experiencing those symptoms. Okay, so the other copy compensates for the changes. And one more thing very important is 2 individuals have 99.5% identical DNA. Each one of us has 99.5% identical DNA, except our gene expression varies. So studying omics, how are we going to study these genetic variations? So it is studied at each level of central dogma. So when we study genes, it is known as genomics. So which focuses on structure, function, evolution, mapping and editing of an information in an organism's DNA to decipher mechanisms underlying cancer. When we study environmental and gene reaction, it comes under epigenomics. It looks at how cells control gene activity to processes like DNA methylation. In case of smokers and tobacco chewers, continuously your DNA gets methylated. So that is known as epigenomics. Then transcriptomics. In transcriptomics, you study the entire set of RNAs. You study mRNA, you study non-coding RNAs. That comes under transcriptomics. And proteomics. So in proteomics, you explore proteins which help in understanding the cellular phenotypes and functions. Metagenomics, you profile microorganisms, you study microorganisms and their influence and their role in the disease. Now, how genetic variation can be studied through MGS? Why we need to decode DNA? Why we need to read the sequence of DNA and RNA? So DNA is deoxyribonucleic acid. It is a carrier of genetic information. The order of bases on a strand of DNA is called sequence. So this order is called as sequence. Suppose this is one human being and all the sequences together present is known as genome. So every human genome contains about 3.2 billion base pairs. So all of us have 3.2 billion DNA base pairs. Every cell in our body contains entire human DNA sequence. So facts and figures about DNA, we have 37 trillion cells in human body, 23 pairs of chromosome. Our genome is 2 meters in length. Just imagine, is it possible for us to sequence 2 meters genome? Yes, but now it is possible. We have 3.2 billion nucleotides and we have less than 1% difference amongst us. As I said before, we have 99.5% similar DNA. So why is DNA important? Because 1% of the human genome contains protein coding region. So though we have 2 meters long DNA, our entire DNA is not coding for proteins. There are introns, exons, intron, exons. So only 1% of the DNA is protein coding region. 20,000 protein coding genes within the human genome. Some amphibians have 1 lakh genes. Genes contain the basic level of information to make molecules called protein. The activity of genes are tightly controlled. Loss of this control can lead to diseases like cancer. Coming to non-coding DNA, 99% of the human genome is not protein coding. Originally thought to be junk DNA with no purpose. But then I'll just tell you in short, coding DNA is DNA and mRNA. Non-coding DNA comprises of rRNA, tRNA, rest everything. Promoters, enhancers, silencers, insulators, specialized RNA molecules like tRNA, microRNA, long non-coding RNA, and structural and regulatory elements. So impact of an error, how the impact is. So you can see over here, suppose this is my reference genome. Over here, this is my second genome. When I compare my reference genome with the second genome, you can see instead of G, there is T. So once there is substitution of G, there will be change in the protein. So if again second times there is similar substitution, instead of over here also, instead of G you get T, my protein formation will completely terminate. So this similar case happens in tumor suppressor gene also. So DNA variation, this variation could be a single letter difference or could include large sections of DNA. Depending on the location, it could have little or no impact, while others could have separate consequences. So impact of DNA variation, genetic code variation could result in non-functioning or truncated proteins. Truncated is nothing but non-functional only, potentially causing a genetic disease. Regulatory elements may not function correctly. The tightly controlled nature of the mechanisms within the cells and organisms could be destabilized. What is RNA? RNA is again carrier of genetic information. We have 4 bases instead of A, we have uracil, and RNA transcriptome varies from one cell to other. RNA is constantly responding to the environment by changing the copy number of transcripts. When I use this term copy number of transcript means mRNA. Your DNA gets converted into mRNA within the nucleus. So as the environment changes, as the cell changes, the number of mRNA increases. Different transcriptome profile at different time points. So you can see why RNA is important. So you can see in case of DNA, all cells are similar only, but RNA is very dynamic. So this is muscle cell, nerve cell, fibroblast. Suppose this is my gene A, gene B, gene C. You can see my gene A is expressed maximum in muscle cell. It is less in nerve cell and fibroblast. My gene B is again twice expressed in muscle cell. It is largely expressed in fibroblast. So like that your RNA varies. Though the DNA composition is same, the gene expression changes. What are proteins? DNA is the carrier of organism's genetic information. It does not carry out the cell's function. It must be decoded into proteins. mRNA is translated into functional protein. Proteins are composed of amino acids and form 3-dimensional structures. Structural and functional diversity are provided by amino acids. So what is DNA sequencing? Sequencing is nothing but we just read the letters A, T, G, C to distinguish between different nucleotides. Now evolution of sequencers. So there are 3 generations of sequencers. The first generation was Sanger sequencing and Maxim-Gilbert sequencing. This sequencer was very slow. It took 13-20 years for an entire genome to be sequenced. The genome project started in the whole genome project started in the year 1990, and it took 13 years. In 2003 it was completed. Then comes your second generation sequencing, which is from Illumina. I largely follow Illumina system. There are other sequences from Iron Torrent. These are high throughput sequencers where you can sequence multiple copies of DNA. And the third generation is PacBio and Oxford Nanopore. So Nanopore is quite portable sequencer, and it is also known as long read sequencer. You can fragment or you can sequence 10,000 copies of base pairs at a time. This is the commonly OR6 series, and it can sequence 3.2 GB of human genome in 3 to 4 days. And Nanopore. So Nanopore is quite handy. You can use it anywhere. Now there are 3 approaches for genome sequencing: whole genome sequencing, whole exome sequencing, and targeted sequencing. In whole genome, you sequence the entire genome, which comprises of coding and non-coding region. In case of whole exome, you focus only on protein composition, that is 1% of the genome. You sequence only exome, which is the protein coding region. And in targeted sequencing, you target specific genes or region of interest. Whole genome, you can identify everything: structural variant, novel mutations. In case of whole exome, you will understand only single nucleotide polymorphisms, insertion, deletions, indels. Now it is not possible to cover mutations in depth over here. And targeted, the coverage is quite high for targeted. It is 500x, and you can target specific regions of the genome. So there's the difference. This is the whole genome, this is the whole exome. So this is the workflow. Initially you can isolate DNA or RNA from a tumor sample. You can analyze it through genomics or transcriptomics. You can similarly take normal data also. The normal data you can take from the blood or something. Then some in silico data is available. There are various databases where you have details of normal sequence genome. One common is Gene Expression Omnibus. Okay, Gene Expression Omnibus is the database. or you can check it, you can compare it to other standard laboratory protocols also. So uses, you can identify the biomarkers, you can identify structural variation, insertion deletions, T cells, microsatellite injury, everything. So this is the general workflow. Initially, entire fragment of DNA is there. You break the entire DNA into small fragments. Then you attach the adapters at the end of the fragment. Then this gets attached to the flow cell. Again, the flow cell is like a glass slide only. There are already short sequences of DNA which are present. This fragmented DNA gets bind to the flow cell. In the flow cell, they undergoes amplification like PCR. They emit lights, they emit red, green, blue. Then you can understand what type of nucleotides are present. This is the final data which you get, A, T, G, C. So you get plenty of sequences like that. And from here, the dry lab part starts. That is bioinformatic analysis starts. So applications of NGS, you identify genomic alterations in case of oral pathology in oral cancer, determine genetic abnormalities in hereditary conditions like cleft lip and palate, to identify main novel mutations, not only TP53, you might get some novel mutations also, and most important is for personalized medicine and precision medicine. So this is my comparison. So in case of IHC, we study single marker or single protein. In case of PCR, we amplify specific DNA sequence. In case of microarray, we see multiple DNA fragments and gene expression. And in case of NGS, we parallelly sequence entire DNA or RNA. So target in case of IHC, it is protein in cells and tissues. In case of PCR, it is cDNA, complementary DNA. In case of microarray, it is mRNA or DNA mutations, and in NGS, it is DNA or RNA. Output IHC, you see protein localization, you get brown color. In case of PCR, you will get amplified DNA, and that you can observe on gel electrophoresis, you can observe on agar gel or fluorescence. Microarray, you will get those light relative expression or presence of mutations, and NGS, you will get base by base sequence data. Sensitivity is moderate to high in IHC, it is very high in PCR, again moderate to high in microarray, and it is extremely high in NGS. Visualization, IHC you visualize using microscope. In case of PCR, you use gel bands or fluorescent curves. In microarrays, you use heat maps or scatter plots. And in NGS, you do bioinformatic analysis. So time taken, IHC 1 to 2 days, PCR 2 to 5 hours, microarray 1 to 2 days, and NGS 1 to 7. This 1 to 7 is with analysis. Common use, so common use, IHC for tumor typing, protein localization, biomarker detection. In case of PCR, you study gene expression, mutation detection, pathogen detection. Microarray, gene expression profiling, single nucleotide polymorphism detection, mutation scanning, and in NGS, you do whole exome, whole genome sequencing and RNA-seq. So the future of pathology lies not just in what we see under the microscope, but what we uncover in the molecule. Thank you.
Oh, yeah.
Thank you, Shraddha, for giving such a complex topic, explaining into a simple one. I hope everyone understood that topic. I would like to call Dr. Shilpa Patel ma'am to give a vote of thanks. And thank you for everyone. So patients, they are sitting, not in lecture, but here they are sitting.
Good afternoon, one and all. And at the outset, I would like to thank all the esteemed faculty from across the country and all the delegates registered for this blended learning national CD program for taking time out of their busy schedule and join us today. A special thank to our Dean Madam for always encouraging us to conduct such events and having an unwavering faith in us. Heartfelt gratitude to our guest speaker for taking the efforts for the trying to passionately deliver this basic topic with such a simplicity. I would like to thank Dr. Avinash, Dr. Pankaj, and the entire Pixel team for the uninterrupted live streaming of today's event. I would like to all the undergraduate and the postgraduate students from MGMDCH who have shown keen interest in attending this program. And I would like to thank technical team, Mr. Sanket, Kumar, Mr. Kumar and Mr. Praveen for their support. And I would like to thank the involved non-teaching staff of MGM Dental College for their timely help. Last but not the least, I would like to thank the Department of Oral Pathology who have worked tirelessly for the success of this event. And a special thank to PG alumni who came long way from this college. And thank you very much.